Good evening, everyone. I'm Dr. Pratik Tambe, Chairperson for the AMOX Endocrinology Committee, and a very warm welcome to all of you, respected dignitaries, faculty who have assembled here today. For today's program, our theme is high risk pregnancy, and that seems to be the flavor for a lot of programs which are being done this month. And we continue in the same vein. We are delighted to have with us a host of dignitaries from across the country to debate various topics in obstetrics, and we would like to proceed without further ado with the rest of the program. I must say at the outset that we are indeed greatly indebted to the office bearers of AMOGS, our president, Dr. Nandita Palchetkar, past president of Foxy last year, and of course, she's the current president of AMOGS, a very well known person throughout this country, and she's always there to support us, encourage us, and promote us whenever there are any academic events in AMOGS. And unreservedly, she gives her permission and her blessings for every single one of our scientific endeavors. We would also like to thank the Secretary of AMOGS, Dr. Arun Nayak. Again, he's been a past president of the Mumbai Society. Currently, he's the Secretary of AMOGS. And again, equally, Sir has also been there for us whenever we needed his blessings and
I'm
his
here.
support. We also need to place on record our gratitude to the chairperson of ICOG, Dr. Mandakini Megh, and of course, Dr. Parag Biniwali, Secretary of ICOG, both of who have given us credit points for all of our events this year, and of course, for also today's event. In fact, Parag is one of the chairpersons, and we'll be introducing him shortly. Can we proceed with the introduction of the chairpersons? Next slide, please. The first of our chairpersons is a legend of AMOGS. He's the state coordinator of AMOGS, Dr. Amay Purandare, a dear friend. He's been the joint secretary of Foxy last year. In the past, he was chairperson of the Food, Drug and Medico-Surgical Equipment Committee. He's the assistant administrator of the Foxy Manyata project. And of course, he's also a managing council member of the Mumbai Society and a mentor for the Youth Council of the Mumbai Society. Next slide, please. We are delighted to have with us Dr. Ramani Devi. She is the Vice President of Foxy. She is the Chairperson of Endometriosis Committee in the past, member of the Consensus for Endometriosis in Asia Pacific region. She has had several wonderful publications to her credit, including the Foxy GCPR on endometriosis, which was published when Dr. Alka Kriplani was the president. She has several gold medals and several accolades to her credit. We are delighted to welcome Dr. Ramani Devi among us today. Next slide, please. Dr. Parag Biniwale is a friend, philosopher, and guide to so many of us who have been there in Foxy as well as in AMOX. Sir is the current secretary of ICOG. He is the president of the Pune Menopause Society, national joint secretary of IMS in 2017-18, website editor for Foxy for several years. And of course, he's also been in the past the chairperson of the Young Talent Promotion Committee and a peer reviewer of the Journal of OBGYN of India. We welcome Dr. Parag Biniwale. Next slide, please. Dr. Abharani Sinha is again a legend in obstetrics as far as academics and teaching is concerned. She's been the past president of the Patna Society. She's a professor of OBGYN at Muzaffarpur, ICOG Governing Council member. Of course, she's the chairperson of the quiz committee in the past. I think that is one of the first times when we were delighted to welcome her to Mumbai. She's also an executive member of the ISOPAP National Committee, and we are delighted to have Dr. Abharani Sinha also with us today. We have two legendary figures in the field of obstetrics. The first is Dr. Bhaskar Pal. Sir will be speaking on the role of low molecular weight heparins in current practice. And we have Dr. Kiran Kurtakoti, who's the Vice President of AMOG. Sir will be speaking on cesarean section, practical tips. For the introduction of our first speaker and to carry on the proceedings further, I would hand over to the chairpersons, Dr. Abharani Sinha, to please introduce Dr. Bhaskar Pal. Thank you so much.
Thank you, Dr. Pratik. Thank you for involving me in this academic program. It's my proud privilege to introduce Dr. Bhaskar Pal, a dear friend of mine, who has been a very great academician and a great Foxian. He's working as senior consultant gynecologist at Apollo Gleneagles Hospital, Kolkata. He has held the various prestigious posts like Vice President IAGE, Chair of AICC RCOG East Zone. He has been the President of Bengal Obstetric and Gynae Society, the Chair-elect AICC RCOG, the FOXY representative to CEFOG 21-23, Vice President FOXY 2017. He has been the ex-honorary biostatistician of Journal of Obs and Gynae of India, and he has authored many books and many chapters in many books. So welcome, Dr. Bhaskar Pal. We are all eager to hear from you, and he'll be talking on role of low molecular weight heparin in current practice. So the stage is yours, Dr. Bhaskar Pal.
Thank you, Abha, for the kind words. It's indeed a pretty difficult job to speak on low molecular weight heparin in obstetric practice in a period of 15 minutes, but I will try my best. I bring you greetings from Kolkata, and I guess this is a sad situation that we are under, that the only thing we can do is see virtually, but I'm pretty sure that we will have all of you in a normal situation when AICOG does descend on Kolkata, whenever it might be. So these are the abbreviations that I'm using: venous thromboembolism, deep vein thrombosis, pulmonary embolism, anticoagulation therapy, LMWH, and unfractionated heparin, if I have to get into that. What I would be speaking on is low molecular weight heparin in thromboprophylaxis, low molecular weight heparin for treating venous thromboembolism, which includes both DVT and PE, and low molecular weight heparin in antiphospholipid syndrome. What I will not be speaking on is LMWH in recurrent implantation failure. That's a matter of debate, and I will leave it to IVF specialists like Pratik to talk about. Just to set the context is, we know that the incidence of VT in pregnancy in UK about 1 to 2 in 1,000, and PE is the major cause of maternal mortality in UK because they've conquered the other preventable causes. We need to remember that we've made so much of good progress in maternal mortality in India that we would be able to prevent the deaths from infection, bleeding, and hypertension pretty significantly, and that is when the deaths from the PE will stick out. A lot of our seniors used to say that VT and PE is a disease of the West, doesn't happen in India. Unfortunately, there are several publications in the non-pregnant population which shows that the incidence of DVT-PE in India, although lower than the Western world, is significant. There is a lovely study from KEM Hospital, which was published around 15 years back, which shows that in the pregnant population, the incidence of DVT and PE in India is around 1 in 1500, so not that low. What happens is that the proper usage of low molecular weight heparin reduces the incidence of VTE by 60 to 70% in non-pregnant patients, and we would expect the same in pregnant population as well, although there is a reduction of 88% demonstrated in one study. We need to understand that although the risk of VTE is the highest in the postpartum period, which is 5 times the antenatal, it does happen during pregnancy and increases with passing trimester. In first trimester, it can happen well, especially in patients who are presenting with hyperemesis or hyperstimulation syndrome. So we will start off with thromboprophylaxis, and if we want to do a thromboprophylaxis, the first thing we need to do is we need to do an antenatal risk assessment. And how do we do an antenatal risk assessment? That all women should undergo a documented assessment of risk factors of VTE in early pregnancy or in the pre-pregnancy period. And the risk assessment is dynamic. It should be repeated if the woman is admitted to the hospital for any reason, or if she develops other intercurrent problems. And this risk assessment should be repeated during the labor and immediately after delivery. So what are the pre-existing risk factors? The most severe ones are a previous venous thromboembolism, a thrombophilia, which may be heritable or acquired, medical comorbidities, age more than 35 years. The incidence of VT is 2 to 3 times more than in women over 35 years when compared to women under 35 years. 35 tends to be the watershed line. Obesity, when the BMI is more than 30, a parity, which is more than 3. Smoking, gross varicose veins, and paraplegia. The obstetric risk factors include multiple pregnancy, current preeclampsia, a cesarean section, a prolonged labor of more than 24 hours, a PPH of more than 1 liter or any PPH requiring transfusion, a stillbirth or a preterm birth, a mid cavity or a rotational operative delivery. And what are the new onset or transient risk factors? They are the any surgical procedure except perineal repair, hyperemesis, dehydration, OHSS, any bed rest which is more than 3 days duration, a fracture, any long distance travel of more than 4 hours, and a current systemic infection which either requires hospital admission or requires IV antibiotic therapy. What are the thrombophilias we're talking about? The heritable ones we talk about are antithrombin deficiency, protein C deficiency, protein S deficiency, factor V latent mutation, and a prothrombin gene mutation. And the acquired ones we talk of antiphospholipid antibodies, lupus anticoagulant, anticardiolipin antibodies, and anti-beta 2 glycoprotein antibodies. What are the medical comorbidities that are included in the risk assessment? Cancer, heart failure, active SLE, inflammatory polyarthropathy, inflammatory bowel disease, nephrotic syndrome, type 1 diabetes mellitus or a type 2 diabetes mellitus with nephropathy, sickle cell disease, and a current IV drug user. So what do we do? If a person does not have a previous venous thromboembolism or doesn't suffer from a thrombophilia, then if she has 4 or more current risk factors, she needs a prophylactic low molecular weight heparin throughout the antenatal period and 6 weeks postpartum. If she has 3 current risk factors, she requires prophylactic low molecular weight heparin in the 3rd trimester and 6 weeks postpartum. If she has only 2 current risk factors, she only needs low molecular weight heparin for 7 to 10 days postpartum. Now, if she's admitted to the hospital in the pregnancy, the LMWH should be continued unless there is a risk of impending labor or a risk of bleeding. The postnatal assessment of the risk should be done to decide in patients, especially in patients that who are going to be requiring it for 10 days, to decide whether they need it for any longer. Now it changes if the patient has got a previous venous thromboembolism. If a patient does not have any thrombophilia and except those with a single previous VT which is related to major surgery, the patients would need a prophylactic low molecular weight heparin throughout the pregnancy. Which means if the patient does not carry a thrombophilic trait and except those who've got a single previous VT which was related to major surgery, prophylactic low molecular weight throughout the pregnancy and not therapeutic. But women who have antithrombin deficiency should be offered thromboprophylaxis with a higher dose of low molecular weight heparin. I'll come to the dosage later, which means either 50% or 75% or the full treatment dose. 50 to 75% of the full treatment dose or full treatment dose antenatally and for 6 weeks postpartum or until they are moved to oral anticoagulant therapy after delivery. Any other heritable thrombophilia, we give them a prophylactic low molecular weight heparin. So essentially, antithrombin 3 deficiency with a previous venous thromboembolism requires either a therapeutic dosage or a higher than a prophylactic dosage, whereas heritable thrombophilia with a previous VT requires prophylactic low molecular weight heparin, or a previous VT without a thrombophilia also requires a prophylactic VT, prophylactic LMWH. Now, antiphospholipid syndrome with a previous venous thromboembolism requires a prophylaxis with a higher dose low molecular weight heparin, which means either the full treatment dose or 75% of the full treatment dose or 50% of the low full treatment dose, and they require it for 6 weeks postpartum or until they are changed to warfarin. Antiphospholipid syndrome with the previous VT or arterial thrombosis, we need to involve a hematologist and or a rheumatologist. And women who've got a recurrent VT, we need to involve the hematologist because they might require higher doses of low molecular weight heparin. What happens with somebody who's got asymptomatic heritable thrombophilia and no previous venous thromboembolism? We consider an antenatal and 6 week postpartum prophylaxis if it is a protein C or a protein S deficiency or an antithrombin 3 deficiency. If it is a heterozygous factor V laden mutation or a prothrombin gene mutation or an antiphospholipid syndromes, then essentially they have a lesser chance of developing a VT during pregnancy. So what we do is, if 3 or other risk factors, we consider antenatal prophylaxis. 2 other risk factors, we consider prophylaxis in the third trimester, and 1 other risk factor, we consider prophylaxis 10 days. Basically, we go one step up. Somebody, for other antenatal patients who are not carrying a heritable thrombophilia, we'll give them antenatal prophylaxis with 4 risk factors, third trimester prophylaxis with 3 risk factors, and postpartum prophylaxis with 2 risk factors. But if they have factor 5 laden or prothrombin gene mutation or antiphospholipid antibodies, then we will do one step lower, which means with 3 risk factors, we'll give them full antenatal prophylaxis, 2 risk factors, third trimester prophylaxis, 1 risk factor, postpartum prophylaxis. And if it is antithrombin 3 deficiency or a protein C or protein S deficiency, then full antenatal prophylaxis and 6 weeks postpartum. In the first trimester, if somebody presents with hyperemesis, we give them thromboprophylaxis till the hyperemesis is resolved. If somebody presents with OHSS, we give them prophylaxis in the first trimester. Anybody having an IVF pregnancy with 3 risk factors for for venous thromboembolism, we give them prophylaxis in the first trimester. In labor and delivery, if a patient is on low molecular weight heparin, we give them no further injections if the patient is having bleeding or pain. Avoid regional techniques till 12 hours after the last injections. Withhold the low molecular weight heparin for 4 hours after a spinal or removal of epidural. If the patient is on therapeutic dosage of low molecular weight heparin, avoid a regional anesthesia for at least 24 hours after last injection. If she is on prophylactic, then 12 hours is fine. If there is a risk of hemorrhage, then you use essentially subcutaneous compression device. And we perform elective cesarean section in between the low molecular weight heparin dosage. Postpartum prophylactic for 10 days if the patient has a BMI of more than 40, and then we need to use appropriate dosage, which I'll come to in a moment. Or if there are 2 persistent risk factors, and all cesarean sections except elective cesarean without any other risk factors will require a postpartum thromboprophylaxis with a pharmacological agent. And what are the agents? Low molecular weight heparins are preferable. The dosage is based on weight, but reduced if there is renal impairment. Platelet count is not required when you are using, we do not need to monitor the platelet count if you are using the low molecular weight heparin. You do not need to monitor the efficacy of the low molecular weight heparin with the anti-factor 10A levels unless the patient throws a venous thromboembolism while on the low molecular weight heparin. That is when you need to do the anti-factor 10A level. LMWH is safe in breastfeeding, and the other the options are in women who are intolerant of heparin compounds. You can use danoperonide or fondaparinide. The only situation where today we will use unfractionated heparin is where there is a low resource setting. Having said that, low molecular weight heparins have become relatively cheaper these days. Or if a patient has got an acute pulmonary embolism with hemodynamic instability, that is where you will use intravenous heparin infusion rather than a low molecular weight heparin. How do you use prophylaxis? Now we are mostly using enoxaparin in our country, and these are the prophylactic dosage that we use. Under 50 kilogram of body weight, we use 20 milligram per day. 50 to 90, we use 40 milligram per day, and 91 to 130, 60 milligram per day. If you remember that much, that is enough. We need to go beyond 130, then it's a good idea to consult a hematologist. So 50 to 90, 40 milligrams, 91 to 130, 60 milligram, less than 50, 20 milligram per day. Now, how do you use low molecular weight heparin in the management of venous thromboembolism? Now, please remember that if you are suspecting a venous thromboembolism, start the patient on low molecular weight heparin pending assessment. And if your assessment shows that it is negative, and then if the patient is, you've got a low index of suspicion, stop the low molecular weight heparin. If you have a high index of suspicion, then you have to consider whether you want to continue the low molecular weight heparin, but it is essentially what you should do is you should retest her after 3 to 4 days. Now, low molecular weight heparin, when we first spoke about treating venous thromboembolism, hematologists said, and that were the guidelines around 10 years back, that the requirement in pregnant women is higher. So while in non-pregnant women you use 1.5 milligram per kg of body weight in a single daily dosage, they recommended in pregnant women you need to use 2 milligram per kg of body weight in 2 divided doses. which means 1 milligram per kg of body weight twice a day. And which one would you use? If you are using the dosage I'm talking about, of course, you are using enoxaparin, but you will do anti-factor 10A, as I said, in extremes of weight or if renal impairment or if there is recurrent VT. Now, what happened subsequently is that when the Royal College of Hematologists audited the usage of low molecular weight heparin in pregnant women, they realized that many people were not following their two divided dosage guideline, and they were while some people were using 1 milligram per kg of body weight twice daily, other people were using 1.5 milligram per kg once a day. And they showed that the incidence of recurrent thrombosis on these two dosage regimens was no different. So they revised their guideline in 2015 to say that you can use enoxaparin either in 1 milligram per kg of body weight twice daily or 1.5 milligram per kg of body weight once daily, whichever one you prefer. And that is how this would come to. In less than 50 kilos, you use 40 BD or 60 OD. 50 to 70, you use 60 BD or 90 OD. 70 to 90, you use 80 BD or 120 OD. 90 to 110, you use 100 BD or 150 OD. That is what is essentially 1 milligram per kg of body weight twice daily or 1.5 milligram per kg of body weight once daily. So why are we talking of low molecular weight heparin? What's wrong with unfractionated heparin? Number one, low molecular weight heparin has less anticoagulant effect. It causes less thrombocytopenia. With heparin, you get heparin-induced thrombocytopenia. You get a type 1 hit and a type 2 hit. Type 1 hit is an idiosyncratic reaction which happens immediately. A type 2 hit is a dose dependent effect which happens in 5 to 7 days, and that is why you need to need to do the platelet count in 5 to 7 days. You don't need to do that with LMWH because the incidence of type 2 hit is much less. There is less, heparin causes bone demineralization, but it happens less with low molecular weight heparin. There is less local allergic reactions. It has the advantage of once daily administration, and above all, it has got similar efficacy to unfractionated heparin. We have already discussed this, that what we will do if the patient is having labor or delivery. But what is important is if you are doing a cesarean section in a patient who's on full anticoagulation and you need to resume full anticoagulation after delivery, please use an abdominal and subcutaneous drain and use interrupted skin sutures. DVT near term, consider unfractionated heparin because it is easy to manipulate. In somebody where you're giving a prophylactic low molecular weight heparin, and suppose somebody has got a cardiac valve replaced and you cannot take her off that for around 24 hours and the patient goes into labor, what we do is when the patient goes into labor, we stop the low molecular weight heparin and start them on an unfractionated heparin infusion. We start with 1000 or 2000 unit, and what you do is you gradually keep on increasing that to keep the APTT at 1.5 to 2.5 times of control, and then stop the heparin infusion about a couple of hours before anticipated delivery. That is when you would stop the low molecular weight heparin and go over to unfractionated heparin. What do you do in primary antiphospholipid syndrome? I have already said what is primary antiphospholipid syndrome. It is association of thrombosis or adverse pregnancy outcome with the presence of antiphospholipid antibodies. The thrombosis could be venous and maybe in unusual sites like the central venous sinuses. It could be arterial, it could be small vessel. In adverse pregnancy outcome, there are three criteria. Either 3 or more consecutive miscarriages are under 10 weeks, 1 or more miscarriage after 10 weeks with a normal morphology, which we say that you have a miscarriage after a positive fetal heart, 1 or more premature birth before 34 weeks with a normal fetal morphology, either due to severe preeclampsia or severe placental insufficiency. And in the ideal world, they should test positive twice at 12-week intervals. Now, if somebody presents with antiphospholipid antibody and previous thrombosis, we have already discussed they need therapeutic anticoagulation throughout they need anticoagulation throughout the pregnancy. But if somebody presents with antiphospholipid antibody with only an adverse obstetric outcome, at the present moment, low dose aspirin and heparin are recommended. You start 75 milligram to aspirin as soon as the pregnancy test is positive, and you start heparin or preferably low molecular heparin, something like enoxaparin, 40 milligram per day. The Royal College guideline is of 2010 says that you start it when the fetal heart is positive. whereas the ACOG guideline says you start it when the UPT is positive. The RCOG is also in the stage of revising its guideline, and at the present moment, the practice is to start both the aspirin and the low molecular weight heparin as soon as the pregnancy test is positive. So to end, VT is a major complication in pregnancy, and its relative contribution to maternal mortality will get higher as we control our deaths from hemorrhage and infection and hemorrhage and infection and hypertension. Pharmacological prophylaxis with LMWH should be used when indicated, and it is impossible for somebody to remember all the risk factors. So essentially, you need to have a care pathway in which the risk factors are written down, and that is there along with the notes, so that when you say that I have done a risk assessment, you've gone around ticking those, otherwise you'll miss them. For acute DVT, you need a high index of suspicion followed by objective testing, but you start therapeutic anticoagulation with low molecular weight heparin pending objective testing. And LMWH is the mainstay of treatment in primary antiphospholipid syndrome. Thank you very much.
Thank you, Bhaskar. It was indeed a very, very simplified version of something which is at times sounds very, very complicated. There are a few questions for you, and the first question is, how effective is low molecular weight heparin in improving live birth rate in patient with 2 or more consecutive unexplained recurrent pregnancy loss?
Now, I assume you are talking about somebody who's not antiphospholipid antibody positive. If you are antiphospholipid antibody positive, your outcome of taking a live pregnancy home without treatment is 10%. Your chances of taking a live baby home with treatment is 90%. If you are talking of idiopathic recurrent miscarriages, there is no benefit of giving low molecular weight heparin. Having said that, we need to differentiate the idiopathic recurrent miscarriage from somebody whose history is very suggestive of antiphospholipid syndrome, but who's tested negative. Some people talk about this as seronegative antiphospholipid syndrome. Some people say it does not exist. But what we do know is that the anti-testing for antiphospholipid has got spatial, temporal, and technical variations. So if the history is very suggestive, and if we counsel the patient and give them low molecular weight heparin and aspirin, we find a good outcome. So please differentiate your idiopathic recurrent miscarriages from those who have a history which is suggestive of antiphospholipid syndrome and who've tested negative. Counsel them and put them on aspirin and heparin, and they will never say no. Their compliance is very good, and usually the pregnancy outcome would be very good in this way.
Okay. Should thromboprophylaxis be given throughout pregnancy in women with previous history of recurrent miscarriages of unknown etiology? I think
no, not really, unless they have a thrombophilic, unless they have a previous thrombosis, or unless they have a thrombophilic trait which is of the level of antithrombin 3 deficiency.
Right.
Parag sir, I just want to make a point.
Yeah, please go ahead.
I think we also need to remember that in those patients, before we label them as idiopathic recurrent pregnancy or unexplained recurrent pregnancy failure, we need to make every investigation done and thoroughly assess before you call somebody idiopathic. So you just can't call somebody idiopathic with only partial investigation or partial workup. It needs to be a thorough workup, and only after you exclude every cause, it's a diagnosis by exclusion that you label somebody as idiopathic. And probably if we really go into the crux of the problem, we are finding more and more positive cases coming up with thrombophilias, with the mutations, etc., being thoroughly evaluated.
Yeah, and that is why Amey, I think it is very important to divide your investigations into first-line investigations and second-line investigations. First-line investigations would include a cytogenetics of the products of conception. If normal, do not bother wasting money about parental karyotyping. Number two, you should have an antiphospholipid checkup. You should have a 3D ultrasound or a hysteroscopy to rule out anatomic defect. If you find all of these to be negative, and as Ameya said, that is when you need to go ahead and test for anti-nuclear antibodies. That is when you need to test for congenital thrombophilias, etc., before you label them as idiopathic.
Yeah.
Because from the therapy point of view, as you rightly said, all types of thrombophilia, low molecular weight heparin therapy is scientifically justified, while in idiopathic recurrent pregnancy loss, when no cause is identified, it is still scientifically empirical. So we need to keep that in mind when you're counseling the patient and telling her candidly that in one, you are in favor of a good prognosis, in the other, it's a 50-50% game, you know.
Dr. Amaya, one question to you. See, in idiopathic unexplained loss, what is the role of immunoglobulins? What is your experience?
And we are going to have a talk on immunotherapy very soon. In fact, we had
Okay.
scheduled that talk last week, but
No,
unfortunately
but
the
not today.
speaker
No,
was double
because
booked. No, it was not today.
since it is
So
not
we
today,
hope
we
to
should
be
answer the
able
question.
to answer it
No,
next.
but
I'm sure Ami and Amaya would give
Summarize.
different answers.
Just
go
I
ahead.
want to make one point, Dr. Pratik.
Yes,
Like what Dr. Bhaskar has said, that if the tests are negative, we take it as idiopathic, as Amir said, that after doing all the tests. But I think the clinical history is very important.
Very
If
important.
the patient fits into the clinical diagnosis, I think we can give empirical low dose, low molecular weight heparin and aspirin.
Also, lifestyle is very important. You know, whether she's following a sedentary lifestyle, whether it's an active lifestyle, obesity, etc. Because pregnancy has negative impact on all these.
Yes.
Obesity may worsen, mobility may worsen in pregnancy, and therefore, in these patients, we need to keep all these factors in mind before we start heparin. It would do good if we start heparin in these patients. You know, you have many of these IVF patients who come with bleeding early pregnancy. They are told you go on complete rest and all that. You are increasing the chance of VT and things like that.
Correct.
So,
Amaya, would you answer Dr. Ramani's question?
I'm about to answer. So, as far as immunotherapy is concerned, Cochrane review says that immunotherapy is not that effective in idiopathic. The early trials did hold promise, but the newer trials say that no, it's not really a cause and effect relationship, because we can't substantially say X person is requiring immunotherapy and that same X person after that giving the immunotherapy has a lower anti-immune or an immune response because of the therapy. Also, the justification ethically to start immunotherapy without its approval by the authorities is still pending, you know. So again, we are doing it more on a research setting.
I have taken the liberty of sharing a slide, and this is from essentially a systematic review published in 2018 for idiopathic recurrent miscarriage. And you can see that there is no benefit of aspirin, low molecular weight heparin, steroid, intralipid, IV immunoglobulin. In fact, there are 6 RCTs on IV immunoglobulin, and there is no benefit. But paternal leukocyte immunization, there are studies in improved live birth rate in some studies, and there is some benefit with progesterones. But the important point is that I think that this is something which is evolving. So if you want to use in immunoglobulins or intralipids, they should be under strict research settings with an ethical permission and not just empirical. I think that is the point Amaya is trying to drive. Science will never progress unless we try new things. But the new things, we should not try them empirically. They should be under controlled research setting with an ethical approval and proper consent.
Absolutely, and extensive counseling of the patient is equally important. The patient has to understand the risks and benefits associated with the treatment that you're going to offer. Bhaskar, there are a couple of more questions, and if the
please go ahead. Let's finish them.
okay. Bhaskar, the next question is: can we combine low dose aspirin, low molecular weight heparin with oral micronized progesterone in patients with recurrent early pregnancy loss? Does it result in improvement in live birth and lower miscarriage?
Again, I will not use aspirin and heparin in somebody who's got an idiopathic recurrent miscarriage, but I would use progesterone in them. On the other hand, the only group in which I will use aspirin, heparin, and miscarriage and progesterone is somebody who's tested negative for antiphospholipids, but a history which is suggestive of antiphospholipids.
Yes.
In them, to cover my tracks, I'll use progesterone. But I do not believe, and there is no evidence to suggest that oral micronized progesterone has any benefit. I would either use vaginal micronized progesterone, of which there is evolving benefit, especially in the PRISM trial, or I will use oral dydrogesterone. I will use any one of these two. I will never use an oral micronized progesterone.
So maybe in a case where there are two two or more early intrauterine fetal devices without a positive APLA, maybe such scenarios one can think of using such combinations. Okay, last question for you, Bhaskar, from Dr. Kiran Sinha, Kanpur. Some recommend use of aspirin even before pregnancy in cases of APLA positive cases. What is your
Absolutely, absolutely, madam. There is absolutely correct. In fact, there are two things I want to say. Is there is you can start the aspirin when the pregnancy test is positive, or you can start it even before the pregnancy test is positive. But however, there is no benefit in starting it beforehand. There is no harm as well. So if you want to start it before the when the patient is contemplating pregnancy, there is no harm. Please remember that when we were talking of progesterones and when we talking of vaginal micronized progesterone in idiopathic recurrent miscarriage, their benefit seems to be if you start it from the luteal phase and then continue it into the pregnancy. So these are the two medications you would contemplate sometimes starting even before the patient is pregnant.
Okay.
Just one point that I'd like to add in the question and in the that has been asked. It would also make sense in using a higher dose of aspirin, that is not 75 but even 150, where somebody is strongly positive APLA and she's preconceptional or periconceptional.
I wouldn't use that. I wouldn't use that because number one, we need to understand that the evidence of low dose aspirin and heparin comes in APLA only from a total of 2 studies which have got only 105 women. And both the studies have tried, one has tried 75 milligram and one has tried 100. I will reserve 150 milligrams of aspirin only in those cases of APLA who had a preterm delivery before 34 weeks because of severe IUGR or severe preeclampsia. And these are the patients in whom I'll use 150. Rest of them I will stick to 75 to 100 depending on what is available. And of course 150, the main role is when you do a preeclampsia prediction at 11 to 14 weeks and they test positive, that is when you start them on 150. But among patients with APLA, I will give 75 to women who do not have a previous preeclampsia or a previous IUGR, and I would give 150 to those who had a previous preeclampsia or IUGR.
The tolerance is also very difficult. 150, if you put the patient on 150, most of them have severe gastritis. Yeah. But on the other hand, obese women, I go straight away for 150.
One more point is that giving 150, because pregnancy itself is a procoagulant state, those who have got very strong APLA on 2 tests in the intervening period between 2 abortions or 2 demises, or those who have vasculopathy of any origin, which may not be proven APLA, but like Bhaskar said, highly suggestive of APLA, it would be sense a lot of physicians are using it as a measure, especially in with now COVID times where coagulopathy and hypercoagulation has been given so much importance.
No, aspirin has been looked at as aspirin versus aspirin plus heparin, and aspirin alone did not show a benefit. Low-dose aspirin has neither shown a benefit in APLA nor it has shown in idiopathic recurrent miscarriage. Unfortunately, the sort of thrombosis that we are talking of in pregnancy, aspirin doesn't seem to be very effective in preventing that. Even for COVID, the COVID physicians are saying that you essentially, although logically it would make sense to put them on aspirin, they are tending to say that it is a low molecular weight heparin that is more effective on preventing a thrombosis. Somehow aspirin seems to work more when you are talking of a chronic thrombosis. In acute, when you are worried about an acute thrombosis, that is where a low molecular weight heparin is a much preferable molecule to an aspirin.
Yeah, absolutely. So thank you very much, Bhaskar. That was indeed an interesting discussion.
My pleasure. Thank you very much. And it's a topic very close to my heart. So and I'm delighted to be here.
Yes. And over to Dr. Ramani Devi to take the session forward. Ramani, you need to unmute yourself.
Thank you, Amox, for giving me this opportunity. I would like to see the screen of Dr. Kiran Kirtikodi. Yeah. The topic he has chosen is very, very common. Day in and out, we do C-sections, but still there are some problems in each C-section is different on its own way. So I think we have none other than Dr. Kiran Kirtikodi, who is the second vice president of AMOX, chairperson of MTP committee of AMOX, chairperson Medical Education Research Training Committee of AMOX, and again Foxy chairperson MTP committee in 2009-2011. And he has organized so many programs for AMOX, and organizing chairman of Foxy AMOX POX Clinical Legal Conference in 2019, which was a grand success. And he is now currently the director of Shashwat Multi-Speciality Hospitals India Private Limited, and Anjeevan Hospital Pune, director of Shashwat Hospital out. And then he is a recipient of Rudra Sinha Prize for the best paper in endoscopy at ASCOG Bengaluru, CS Don Prize for the best paper at ASCOG Chennai. Publication, he has got a lot of publications in Foxy Focus and authored Medical Abortion, Drug Regimes, RPL, Foxy Focus, and he has given more than 150 talks at national and international conferences. I welcome Dr. Kiran Kurtikodi to give your talk on this very commonly done surgical procedure. Over to Dr. Kiran.
Hello? Hello?
You are audible, sir.
Sir, we can hear you, but your screen is not seen.
Yeah. Should I carry on with my talk?
Yes, please, sir. Please go ahead.
Yeah,
Yes,
thank you.
go ahead.
Doctor, thank you, Dr. Ramni Devi, for that kind introduction. It's a great pleasure for me to interact you as always, whenever you are in Pune, outside Pune, or on telephone to interact with you. Thank you, Pratik. Thank you, AMOX, Amaya, and everyone in AMOX for involving me in this particular talk. Well, when it comes to cesarean section tips, everyone has a story to tell, and so also I have a story to tell. Each one of you has done so many cesarean sections. Probably many of you must have done much more number of C-sections than me, but everyone has a story, so I'll be telling my story of C-section tips and tricks. Now, medicine is a science of uncertainty and an art of probability. And more than medicine, I think William Osler should have replaced the word medicine by surgery, because it's a science of uncertainty and an act of probability. Probably you feel that this C-section is going to go correct, and there is an uncertain event which happens and makes you run here and there. So, what Napoleon Hill has famously said, one second. What Napoleon Hill has famously said, yeah. Now, why are there some difficulties in C-sections? There are innumerable reasons why there are difficulties in C-sections, like access to abdomen and uterine access, craniopelvic relationships, abnormal positions, prematurity, conjoint pains, and many others. So let us see how we can overcome this issue of problems in C-sections. Now, all of you know that C-sections have been categorized into four. The category 1 and 2 C-sections are immediate threat to life of woman or fetus. Category 2 is maternal or fetal compromise, which is not life-threatening. Category 3 is no maternal or fetal compromise, but needs early delivery. And category 4 is C-section on demand, or delivery time to suit the woman or the staff. Now, the most important thing that we need to remember is perform category 1 C-sections within 30 minutes of decision, and perform category 2 C-sections within 75 minutes of making the decision of C-section. So this is the most important thing or slide that one must remember. Now, starting right from beginning, antibiotic prophylaxis. The NICE guidelines clearly say that prophylactic antibiotics should be given pre-operatively. Many times what happens that C-section has been decided, and once the anesthesia is introduced or given, then the antibiotic prophylaxis starts. But please remember, it has to be pre-op or pre-anesthesia. Now, what is the dose? What is the antibiotic recommended? It is epalazolin, which is recommended. But most important, read the last line. Do not use co-amoxiclav, because chloroamoxiclav have been shown to cause neonatal issues. Now, coming to anesthesia, something about anesthesia. What is the most important thing that we need to learn in to prevent anesthesia-related complication is hypotension. So, to prevent hypotension, one is of course preloading the patient with the lactated ringer solution. Keep in hand mephentermine, keep in hand the hemaxin and starch-based colloids. Now, coming to preparation of the incision site, again, before you start, we need to remember that the incision site needs to be prepared properly. Now, whether you are going to plan a C-section or going to do an emergency C-section, the site of the incision has to be planned. So, even if you are going to give a trial of labor, for a primary or multigravida, whatever, the C-section site has to be prepared quite before. Now, the C-section height needs to be prepared either by chlorhexidines or iodophores. Number one. Number two, you need to remember is never go back to the middle of the prepared area with the same swab and drape the abdomen, of course, to prevent contamination. Here we must remember is last slide. There has to be at least a 3-minute of contact time between the iodine and skin for a good asepsis. We need to remember for the further slides. Remember this sentence. Now coming to bladder catheterization, many a times it has been a habit of gynecologists that once the anesthetist gives spinal anesthesia, we tell the anesthetist ki aap bhi kar lo catheterization. So this is a very wrong practice because the neonatal adverse outcomes are more if the induction and delivery interval is more than 8 minutes or if the incidental delivery time interval is more than 3 minutes. Now if you allow the anesthetist to catheterize, then what is going to happen is your painting and draping is going to be at a little later stage, and again these are the likely complications that can happen. Plus the anesthetist has to tackle to the hypotension or the spinal hypotension which can carry on. Anesthetist may be occupied with should ideally be occupied with the patient. So never leave it catheterization to the anesthetist. Now anesthesia. Many of us are aware that we are commonly the 25 gauge 2G needle is used, but please remember the newer needles, that is the Vitacare needle 27 number, is a very good needle for obstetric anesthesia. Why? Because it has a blunt pencil tip point and is designed to spread the tissue. These are the Vitacare needles. If at all you can see the screen, these are the Vitacare needles. So Vitacare needles, these are blunt tips and they have a bevel at the side, as against these the conventional spinal needles. Now these conventional spinal needles, that is the Quincke needle or the Tuhoi needle, which is at the last, they can cause more amount of CSF leak and cause post-op headache. So the recommended needles are either the Vitacare or the Sprotte needles. And Vitacare, if you use 27 gauge Vitacare needle, tell your anesthetist to use these needles, and then you will find that there is almost no incidence of post-spinal headache. Now coming to anesthesia issues, these are the 3 anesthesia issues which we need to tackle whenever anesthesia is given. Inappropriate level, good sensory loss but poor muscle relaxation. Now with the advent of in many institutes, lignocaine is not being used now because of cauda equina syndrome. So many a times we are shifting to anaven or sensorcaine, and sensorcaine we all know gives a good sensory loss but gives a very poor muscle relaxation. So in our pharmacopoeia, we need to have a drug called as fentanyl and dexmed. Fentanyl is for procurement of fentanyl, what we need is a license. However, you can procure fentanyl 5 ampules per patient in your hospital by giving a certificate in triplicate. So please keep fentanyl ampules ready in your operation theatre. Now coming to trolley. One must remember that trolley should have very limited instruments. There should be a very constant sponge count. For example, in our institute, we have a constant sponge count of 5. Always remember the needle dictum, needle is always should be on a needle holder, and there should be no loose gauze pieces except those on the sponge holders. Now coming to the skin incision. These are the various types of skin incisions that are available. The Finance style incision, the Maillard and Joel Cohen. We'll be talking only about the Finance style and the Joel Cohen incision. The Finance style incision, as you all know, is a curved skin incision 2 fingers above the symphysis pubis, whereas the Joel Cohen incision is a single straight incision 3 cm above the pubic symphysis. We all know the advantages and disadvantages of transverse C-section as well as the vertical C-sections. Okay. Now coming to the methods of C-section, this is the Finance style care method, which consists of a Finance style skin incision, that is a low skin incision, and all the dissection is a sharp dissection. Please remember, all the dissection is a sharp dissection, and there is manual removal of placenta. As against this, which is the Joel Cohen method, there is a Joel Cohen skin incision. All dissection is a blunt dissection, and the placenta is removed spontaneously. Now, about 10 years back or 15 years back, there was another method which was popular, that is the Misgav-Ladakh method, wherein they took a Joel Cohen incision with a manual removal of placenta and blunt dissections. And this is the modified Misgav-Ladakh incision method, wherein the skin incision is a Finance style 1, all the dissection is a blunt, and the placenta is removed spontaneously. So various permutations and combination of incisions are there. But my bottom line will be Joel Cohen's method is suited for the best, especially for a repeat C-section. It is 3 cm above the pubic symphysis, or you can easily draw a line connecting the anterior superior iliac spine, and it is 3 cm below the anterior superior iliac, below this particular line. So this is a Joel Cohen line. This will avoid any adhesions or tumors, especially in the lower segment, and is best suited for repeat C-section. Now, with the vertical previous incision, which incision will you go? It is better to take a Joel Coy's transverse incision where the vertical incision for the previous C-section has been taken. This will avoid the chances of insular hernia later, as well as improve the post-op recovery. Now, coming to adhesions, the main dictum that one needs to know about adhesions is you should know what not to cut. So as soon as you open the abdomen, what you should not cut is the bowel, the bladder, the ureter, and the blood vessels. You should not cut that. Apart from that, everything can be cut till the time you approach the lower segment. That is the thing that we need to remember, especially in previous C-sections. Yeah. Now coming to the bladder peritoneal incision, it is said that the bladder should be separated only up to 3 cm below the peritoneal incision line, not more than 3 cm, because unnecessary resection is likely to open up the bladder plexus and cause excessive bleeding. And then the lower segment incision can be taken 1 cm below the incision taken for the peritoneal reflection. Now coming to the uterine incision, there are various types of uterine incisions which are mentioned in the books. Transverse lower segment incision is the commonest one, and we will stick to it. We will not go to the classical or a J shape. J shape you can do extend if the baby is large, or if there is a transverse lie, or if there is a difficult extraction. But please remember, never take an inverted T incision, because inverted T incisions, we have a lot of incidences wherein the patient had the previous C-section was an inverted T. It was not mentioned in the notes, and the patient landed up in the rupture uterus in the next pregnancy. So remember, transverse lower segment incision, commonest one, and if at all you want to extend a bit, then a J shape. Now opening the lower segment. Earlier, if you remember when we studied, the lower segment was opened by sharp dissection and cutting. But now the guidelines clearly say that it should be opened for up to 3 cm with a knife, followed by the blunt dissection with finger to extend the uterine incision. Now coming to the main part, that is removing of the fetal head. These are the four issues which we need to tackle when we remove the fetal head: floating head, deeply impacted head, the breech, and a transverse position. Now we'll discuss about the floating head. The commonest way by which the floating head, the easiest way that the floating head can be delivered is as soon as you open the lower segment and drain out the liquor, the head gradually descends on your palm, and then you can easily deliver. But if at all you want to apply a ventouse forceps, then of course you can go ahead and apply a ventouse forceps. Now whenever we apply a ventouse forceps in the lower segment cesarean section, one must remember this is the barred ventouse. It has to be applied at the pivot point, or it has to be applied on the occiput. Never apply the ventouse on the anterior fontanelle, because if you apply on the anterior fontanelle, the chances of tentorial tears are very high. So this is the way we can easily apply the ventouse without causing any lateral tears or lateral laceration. And yeah, so this is ventouse application. Now the other way, if at all you want to apply, the other method to extract the fetal head is by the application of forceps. Now in a forceps, just as in an outlet forceps, it should be a straight bladed forceps. Just as in an outlet forceps, we have the right and the left blade. In a C-section, whenever forceps is applied, there are only two blades, the anterior one and the lower one. So one must remember that the lower blade has to be applied first, followed by the anterior. The heads need to be flexioned by attraction, and gradually it can be removed through the abdominal incision. The delivery has to be by a controlled extension. The video courtesy is by Nozer Sheriar in this particular case, who is a close friend, philosopher, guide of mine in Foxy. So this is the application of forceps at C-section. Yeah. Now coming to the deeply engaged head, there are various methods again by which you can recover a deeply engaged head. I will discuss the option B. This is in case you don't know the Patwardhan's manual. This is one of the easiest way. You can disengage the vaginal head by either telling another assistant who is not washed with you to put 2 fingers in per vaginally, disengage the head so that you can manually remove the head. Or the other one is the Patwardhan method. Now in a Patwardhan method, in the classical Patwardhan method, when the back is posterior, you can remove it. First of all, what you need to do is you need to remove the right arm and the left arm first. As soon as you open the abdomen, you open the uterine incision, one arm has to be removed. The back, always remember here, the back always has to be kept anterior.
Sir, video is not
Yeah.
playing, sir.
So it is playing on my side. Now is it playing?
No.
Okay.
So maybe you go back one slide and come back again.
Okay. Yeah. I'm going back one slide. I'll come again. So
Yeah, it's
No,
seen now.
clear.
yeah. So this is the patellar spanier, wherein you take the incision on the lower segment.
Not seen.
Not seen.
No, there was a brief flash where the beginning of the video was seen, but then the
Okay.
actual moving picture is not visible now.
Okay, I think then we will show it at the end of the talk so that in case someone wants to see, because I'll have to minimize everything. Huh?
No worries, sir. Please go ahead.
Okay. Yeah. Okay. Okay. Now coming to the transverse lie, one must remember that whenever we deliver a patient with a transverse lie, after the incision on the uterus, just remember, put your hand inside and convert the transverse lie into a longitudinal lie. Whatever it is on the left flank, if you're at all you are a right-handed surgeon that is standing on the right side, whatever is in the left gutter, just take it down and convert it into a longitudinal lie. Either it can be a cephalic lie or it can be a breech, and just deliver the patient. Please remember, in these cases, avoid a inverted T incision. The breech delivery is just like any other vaginal breech delivery. It is not different from a vaginal breech delivery. The limbs are manipulated through the natural range of movements. That is, you first take out the legs. If they flex it, insert your hands into the popliteal fossa, flex the knees and bring it out. Then one arm at a time, and then the aftercoming head. I have never personally applied any forceps in this particular case for a C-section for the aftercoming head. Again, in multiple deliveries, the plan of action is the same, but one must remember that whenever the first fetus delivers, especially in a monoamniotic monochorionic twin, once the first fetus delivers, then you need to immediately clamp the placenta 2 times, doubly clamp, so that it prevents the retrograde bleeding from the placenta. Now, the most important thing again, whether to remove the uterus or to exteriorize the uterus or not to. Now, NICE guidelines clearly recommend that intraperitoneal repair of the uterine C-section should be undertaken, and it is not, exteriorization is not recommended. However, in my personal private practice, and I know many of you in your own practice are taking out the uterus, which has got different advantages. One, the uterine anomalies, if any, can easily be diagnosed. For example, accessory horn, para-ovarian cyst, ovarian cyst, that can be easily diagnosed if the uterus is exteriorized. If the uterines need to be tackled or the internal iliac needs to be tackled, then exteriorization is mandatory. There is no change in the morbidity. Also, if at all you want to do a myomectomy at the time of C-section, again exteriorization is mandatory. Now, handling hemorrhages. Okay, in our PG days, whenever we do the C-section, okay, what the first thing that we were taught is take the both angles first, because the uterines come through the side and then they enter through the laterally. So first take both the angles first. And if at all you want to, you can do a uterine artery ligation. I'll be showing a video of uterine artery ligation, which we are doing in all high risk patients. Okay, so this is the head end. Yeah. So you exteriorize the uterus, as here you can see. You exteriorize the uterus. Here you can see you can apply LS forceps just below the incision on the posterior side, where the uterosacrals enter the uterus or are attached to the uterus, and take the entire leash of the uterines therein. So this is the way the uterine ligation we are doing in all high risk patients to prevent PPH. Now, if at all you want some more of hemostasis, what we can do is on the trolley. If you remember on the trolley, what I have shown is you should have 2 sponge holding forceps. Now here you can see we can easily clamp both the infundibulopelvic and the uterine together by a single sponge holding forceps. Okay. So this is the head end, this is the foot end. The uterus is, whenever we apply the sponge holding forceps at the, here you can see the sponge holding forceps being applied. Make sure that you remove that the tube is excluded. Yeah, this is the clear picture. This is the infundibulopelvic ligament. This is the lower segment, and this is the fallopian tube, and this is the upper cut edge. So here, if at all you take the sponge holding forceps, which is given here, and apply the sponge holding forceps across the infundibulopelvic right up to the edge of the uterus, which will take the IP as well as the uterine, then you can see that there is no bleeding at all, or the edges of the incisions are absolutely bloodless. Here you can see that there is no absolute bleeding from the edges. So this is another way by which you can check the hemorrhage. I will not be showing the internal iliac artery ligation and other ligations, because the next panel is on obstetric hemorrhage, where it will be shown. The U suturing technique, when I was doing my PG in Mumbai, so this is a technique which was very common in Wadia Hospital and TAIM Hospital, that is the U suturing technique. In the U suturing technique, you just take anterior posterior stitches on the uterus, okay, and then you compress the uterus by full thickness penetrating sutures through the anterior and posterior uterine walls, and this is how the uterus looked after the surgery. So this is the U suturing technique. If at all you are not practicing a B-Lynch, then this is a very simple surgery that you can do. Again, coming to the other uterine compression techniques, these are various sutures: Cho suture, Heyman suture, we have Gunashila sutures, Hakenda sutures, and n number of sutures. I'll just show a video of a modified B-Lynch suture that we normally take. Now, suppose imagine that you have sutured the lower segment completely, and before you put the uterus back into the position, back into the abdomen, there is some flabbiness in the uterus. We again should not open the lower segment to take the B-Lynch. This is the way you can keep the lower segment intact, take the incision, pass the needle through the fundus so that the suture is stabilized, then go back. From once you go back, just above the incision of the uterosacles, you can take the horizontal incision. So this is a horizontal incision, horizontal suture. Again, come back to the fundus. Again, take the fundus. Again, take a stay at the fundus. Go forward and take it through and through to the lower segment. By this particular way, there is no need for you to open the lower segment even once it is sutured and if the uterus becomes flabby. And this is how you compress the uterus and tighten the sutures. This is as good as a B-Lynch suture, okay, without opening the lower segment. Yeah. So this is one of the modifications of the B-Lynch sutures. Okay. Now B-Lynch sutures are definitely Now coming to abnormal placentations. Many times what happens is, whenever we are doing a lower segment C-section where the placenta is low lying, grade 2A and above, in that particular case the placenta is at the incision site. So here one needs to be very fast, access the membranes by insinuating fingers between the placenta and uterine wall, rupture the membrane, take out the baby first as soon as possible, and then take out the placenta by manual removal. Now coming to the dilatation of internal os. Personally, in my practice, I never do the dilatation of internal os, especially in an elective C-section or whenever the cervix is less than 5 centimeter dilated. But many a times it is said that if the cervix is not dilated, then you have a set of Hagars, or most commonly what people out here do is just dilate them by the tip of the index fingers in planned sections. But I do not do, but many of the people are advocating dilatation of internal os. There is no reduction in the risk of post-op maternal fever or wound infection. Now coming to the uterine suture, all of us are doing a single layer suture, interrupted hole thickness suture with number 1 or 10 vital. This is the thing which I do commonly. But a nice guidelines are now coming up, the recent 2020 guidelines which have been updated. They are saying that closure of the uterus in a single layer is uncertain, and hence it has to be closed in 2 layers. I really have, because again the earlier guidelines were in 2014 and these are the new guidelines in 2020. But however, all of us are doing uterine suturing with hole thickness using number 1 or 10 vital. Now coming to the rectus sheath. The rectus sheath has to be sutured by a delayed absorbable suture. We do not do a proline suturing in repeated rectus sheath closures also. I have done previous C-sections, even up to 7 C-sections, we are not closing the rectus sheath by proline. A delayed absorbable suture is one of the best. Now here, when we are taking to prevent lateral herniation or to maintain the tensile strength, what we can do is a near far near technique, wherein if at all you are inside, once you take the needle through the lower border of the rectus sheath, 3 millimeter, then the upper border should be at 6 millimeter. Again, when you come back on the lower border, it should be at 6 and the upper at 3. 3. So near, far, near technique should be there to suture the rectus sheath. Now coming to prevention of rectus sheath heme. These are the various grades of rectus sheath hematomas. Mild hematoma, which is an intramuscular unilateral, does not dissect along the fascia. Moderate one, that is intramuscular, it will dissect along the fascia and may involve both the recti muscles, but without extension into the prevesical space. And grade 3 is extension into the prevesical space. Now rectus sheath hematoma, why does it occur? Because whenever we are opening the rectus sheath, at that time, if we give too much lateral pressure, then the inferior epigastric artery is likely to be damaged, or the small arteries which feed the lexural muscles are likely to be damaged. So whenever we start closure, we should take the mop count, instrument count, and once we start closure, if at all you are in a habit of closing the peritoneum, you do close the peritoneum, or the peritoneum and the rectus muscle can be taken as a whole, but ensure that there is no bleeding artery or vein which is left above the peritoneum and below the rectus sheath. So this is the most important thing one must remember to avoid a rectus sheath hematoma. Then closing of the subcutaneous layer. As you see in this picture, usually the subcutaneous layer is about 3 cm, but if at all you have an obese patient, then it is advocated that the subcut layer of more than 2 cm should be closed either by use of a monocryl or a 2,0 vicryl. That should be good enough. We never advocate putting of subcutaneous drains unless of course the BMI is more than 50, which is very unlikely that we would be operating a patient of BMI more than 50, but subcut drains are usually not advocated in C-sections. Now coming to the skin suture, the final picture is what matters. Absorbable suture is the best, and we are commonly using either 3,0 monocryl or 2,0 vicryl for skin sutures. Now for some rare problems, okay, torsion of the uterus. Now many a times what happens is there were 3 incidences wherein once we did a C-section, and when we tried to locate the bladder was not there. So when we probed much into it, what had happened that the uterus was totally dextro-rotated, torsion, and a C-section had been done through the posterior wall of the uterus. So one must remember this: the torsion of the uterus is a rarely occurring condition, but one must keep this in mind. Bladder injuries, of course, bladder fundus, catheter in the uterine cavity. So these are rarely seen, and if at all there is an injury to bladder, it is better to suture there and then after the uterine closure is there by in 2 layers. Ovarian vessel hematoma and infundibulopelvic ligament, again a very rare, but we need to remember that. And of course, MOPS can cause chemical peritonitis, so it is better that you clean the mop by which may have lint. Avoid mops which have got a huge amount of lint, and if at all it has lint, then it is better that you clear it with normal saline and then use the wet mops. I think, yeah. Before we move ahead, injuries to the newborn. Now, many times, I don't think there is any gynecologist who has not injured the newborn, of course, inadvertently, either through injury on the scalp, or through a dislocated soldier, or probably a fracture clavicle. But these are the things that one must remember that can happen to a neonate, and we must avoid haste or difficulty in fetal extraction. Again, comes to the final slide. If at all you are going through hell, keep going. You will reach somewhere. Be out of hell. Thank you, Dr. Pratik. Thank you, Amox, and thank you everyone for listening patiently to this particular talk from a novice like me with more experienced chairpersons like you. Thank you so much.
Thank you, Dr. Kiran, for your excellent presentation.
Thank you.
One question for you.
Ji, madam.
A patient with atonic PPH in the first pregnancy,
yes,
he undergoes internal iliac ligation.
Yes.
The same patient you are taking her
yes.
up for repeat LSCS.
Yes.
And the primary cause of PPH is likely to happen.
Yes.
So, what are the things you will anticipate in such situation?
Yeah. See, basically, the patient has gone into PPH in the primary case. Was there any antecedent factors like did she have PIH? Was there a prolonged labor? Were there twin pregnancies, etc.? So, in case these are there, then you anticipate. Then these are non-recurrent indications. Of course, this patient, of course, is likely to go into an elective C-section. Whenever we are doing an elective C-section in such particular case, we should anticipate the same kind of problem that has occurred in the previous one, and be prepared. So what are the ways by which we can be prepared? Is, of course, as soon as you open the abdomen, you have to, as I said, application of sponge holding forces on both sides, and doing uterine artery ligation, selective devascularization right at the beginning. I think that should take care of her problem.
See, the problem here is once iliac ligation is done in the previous section, there are chances that lot of these collaterals will be open.
Yes.
So
yes.
even though if you are going to ligate the infundibulopelvic and the uterine artery, still your bleeding may not be controlled. See, this was
Yes.
a practical situation what I faced, and finally I had to land up in a hysterectomy. I tried always.
Yes.
Interiliac ligation, I mean, already interiliac was gone. So a lot of collaterals. So I tried with B-Lynch because I know there is no point in doing infundibulopelvic and uterine. So anybody has got such an experience, I would like to hear from you. I tried B-Lynch also because B-Lynch is out of that collaterals.
Yes,
See,
yes.
only it is a muscle contraction,
Yes,
muscle
yes.
compression.
Yeah, of course, in such situations,
So-
one need to counsel the patient that a obstetric hysterectomy may be required. And if
Yes.
at all the bleeding is not controlled by everything, then of course you go ahead and do obstetric hysterectomy, which you have rightly done.
Yes. So that's a message.
There is
rare situations we can have that.
Yes.
Okay.
Yes.
Kiran, a few points just want
Yes.
to make. One,
Yes.
I think the pre-op and the post-op period, as with respect to every surgery, are very important. So a checklist should be there in the OT for every cesarean section, and it should be a team ethic and a team exercise to go through that checklist and see that every point is checked. Where you are anticipating blood loss, it is wise to be sure rather than sorry and ensure that the blood is cross-matched and kept ready so that there is no wastage of time. Also, one practical point is that the NBM status of the patient is very important. You need to ensure that the patient gets the antiemetics as a pre-op medication so that we minimize the chance of any kind of vomiting, aspiration, unpleasantness, or even Mendelssohn's syndrome. During the intra-op period, it is essential, like you said, that hemostasis is mandatory. But we must also not be in a haste to close the abdomen and ensure that all collected blood, vernix, secretions should be mopped thoroughly, because it reduces the risk of post-operative morbidity, post-operative fever, peritonism, peritonitis, etc. It's simple thing, but we need to ensure that it is done. Another important point is that once we've closed the abdomen, we obviously move on for vaginal toileting, and using some kind of povidone iodine or betadine for cleansing the vagina will reduce the risk of post-operative endometritis. Again, we want to make the patient's new motherhood phase as the most memorable phase for her. We don't want her to be febrile, to be lying in bed, etc. And last but not the least, early ambulation, also early starting of fluids, bringing her back to normal, and early initiation of breastfeeding should be an essential component of the entire cesarean section package.
The entire Manyata playbook, basically.
Yes. Then one more thing is, never forget to close. I personally feel we need to close the peritoneum. That is the parietal peritoneum. Even if you don't close the visceral peritoneum, nothing is going to happen. In the event if the patient is going to have an inferior epigastric leak, at least this will be confined only to the supraperitoneal region. Suppose if the peritoneum has not been sealed, it will go into the peritoneal cavity where it's very difficult for the patient to get her back, because volumes and volumes of blood can be collected in the peritoneal cavity. I think this is another important point. And one more thing is, when you do the repeat section, we can definitely identify the patients whom the previous parietal peritoneum has not been closed, because it's like something like it will be adherent to the anterior abdominal wall.
I remember just immediately after my MD, when I was starting to assist my grandfather's brother, that is Dr. V.N. Purandare, and I was using all the shortcuts possible to impress on him that how fast I could finish the cesarean section. So he looked at me and he said that, listen, if you take off your clothes, you take them off layer by layer. So when you finish your act, you put on the clothes layer by layer. So don't try to cut short. Just like you cut every layer or incise every layer to reach the cavity, it is your responsibility to close the layer and restore the anatomy back as possible to the pre-surgical state, because then only you are ensuring that you have minimized the damage and minimized the harm. I think it's a key point of key surgical principle, because this is not the end of the story, because the obstetric career has just begun. You have altered and deviated the obstetric career by doing a cesarean section. You need to ensure that it doesn't cause even more harm, both in closure of the uterus and closure of the peritoneum. So we are seeing more and more cases of adherent placenta, placenta accreta, and all is being blamed to improper closure of the uterus. Rupture uterus was also being thought to be because of inadequate and improper closure of the incision, and so also adhesion formation again goes to if we don't close the layers properly. Herniation and all other issues are there. Now the big question comes is that what Kiran emphasizes, and I think this is a ground level question, is that none of our patients are willing for a cesarean section as a default method or choice of birth, route of childbirth, route of childbirth. So when we counsel them, we need to explain to them our intentions of that, and we have to emphasize to them that the reason why we are doing the cesarean is that it's a life-saving procedure for the mother and the child, or the child and the mother, depending upon the circumstance. So it is not that we want to do it because of convenience. We want to do it because of compulsion to improve the outcome of the patient. So I think a lot of counseling, like Dr. Ramani Devi and Dr. Kiran have said, is required when the decision making during childbirth is there. And that's why in Manyata, cesarean section is one of the key elements which we involve in the training process, because it's something which is a deviation. The whole team has to be in the same page, in the same wavelength. And even though it's a cesarean section, if you counsel properly, give her the right experience, the right decision making, her feedback to you is that, yes, I didn't undergo a normal delivery, but my cesarean went off uneventfully. So it's a pleasant experience for the next childbirth. She keeps that in mind. I'm sure all of you all agree that the scars of the previous labor are carried on to the next labor. And I think that if we take the onus on us to ensure that we make that extra effort, every cesarean will be a pleasant experience, and every subsequent delivery will be even a more pleasant experience.
Just can I add one point, Dr. Pratik?
Yes, of course, ma'am. Please go.
Dr. Kiran, it was a wonderful deliberation. One thing I'll just like to say, like in obstructed labor, where to give the incision, I think that point has to be emphasized, because the incision has to be higher up in obstructed labor. So that point, I think it was missed. That was a very important point. And second, what happens in suturing in cases of obstructed labor? Many times what happens, the lower segment is thinned out, it goes down, and they're just stitched the posterior wall with the anterior wall. So these are the few points that we need to train our juniors, how to look for the lower segment, how to hold the lower segment. So these are a few points I wanted to bring in. Thank you so much.
And sometimes there will be a vertical downward extension from the lower uterine segment. That also they have to be very careful, and you need to have a very strong suturing, definitely in 2 layers, so as to avoid repeat rupture
in the next pregnancy. Yes.
I think,
and with Patwardhan, I think we are seeing very few tears. Initially, when we in our PG days, when we were taking out those babies by just pushing, the assistant used to push from. But now when we are doing this Patwardhan, this lateral extension has come down a lot. So I think Patwardhan is a thing that we need to teach our juniors. That's very important.
I think Pratik will remember our boss during training used to tell us that when you see the lower segment, mentally you have to divide it into one third, and one third. And you will decide where you will take the incision in this one third, and one third. If it is a straightforward, well-formed lower segment, concentrate on the middle one third. If it is a obstructed labor, focus on the upper one third. And if it is a placenta previa or something like that, concentrate on the lower one third, because that's the point where the bleeding will occur. We were trained to visually map the lower segment and divide it into one third. I think Pratik will remember that we were taught this. Another important
basic principles of cesarean section, as explained the Vadia method.
Yeah, and one more point, like you said, as far as Patwardhan's method is concerned, it is an absolute essentiality for every obstetrician to know about the Patwardhan's method. So also the application of forceps or ventouse. One of them you should be confident and competent at cesarean, because you don't want to be in a situation where there is a delayed extraction and that causes a delayed cry. The forceps should be used carefully, judiciously, correctly, and as delicately as possible. Pratik will also remember Dr. Nozar Shariar used to tell us that you should have only your index finger between the two blades, and your role is to elevate and extract. Otherwise, in vaginal delivery, it is mainly to extract, not to elevate. Nature takes the course of elevation. Here, your main role is that you need to elevate, and then once you elevate, you extract. So there's a slight change in your thought process when you're using. These are technical nuances, but since Kiran is talking about tips and tricks, I think the whole, as every cesarean you encounter something new, you start evolving these techniques. But you must ensure that you develop some kind of a protocol mentally and for your team when you go in for every cesarean section.
And you need to have the appropriate forceps. You can't have the regular outlet vaginal forceps, because the curve will defeat your entire pull. You need to have the straight branch. You cannot have the angled branch.
Yes.
I think.
Any closing comments from any of the chairpersons before we move ahead?
I think Kiran would like to congratulate you. You have spoken from your heart. You have spoken for points which are extremely practical and which are going to be beneficial to all the attendees, because they are something that we encounter on a day-to-day basis. They will positively impact outcomes, I'm sure. On behalf of the other chairpersons, Dr. Ramni Devi, thank you, madam, for joining the AMOGS family, and Dr. Abharani Sinha, who is a close friend. Thank you for also joining the AMOGS family.
Thank you, Amaya.
It's my pleasure.
Yeah, and Pratik for inviting me this evening. We would like to thank the speakers, the organizers, the sponsors, and all the panelists, because I think you are the people who are going to be the real frontline warriors who are going to save the woman from bleeding and reduce maternal mortality, as Pratik takes you through the interesting panel.
Thank you.
Thank you.
Thank you, Pratik.
Thank you very much, respected chairpersons and our two esteemed speakers, Dr. Bhaskar Pal and Dr. Kiran Kurtakoti. That was a fantastic 1.5 hours where we had some very wonderful, engaging discussions on so many aspects. Shimon, can we have the presentation back up, please? So we are going to do a quick panel. It's on obstetric hemorrhage. The topic is not new, but we have a host of very senior and eminent faculty. First and foremost, we have Dr. Pranjal Sharma. She's a zonal coordinator of AMOGS. She's been the organizing secretary for the annual AMOGS conference, which we had in February. It seems like, such a long time ago when we actually physically met and we were all together in Amravati. She is the vice president of PCPNDT for the state IMA for 2018 and 19. And she's been the chairperson for Beti Bachao Beti Padhao for the state IMA for 2019-20. She's done a lot of pioneering work in the field of adolescent health and, of course, in obstetrics as well. We welcome Dr. Pranjal Sharma. Thank you so much, ma'am, for joining us. Next slide, please. We have also with us Professor Dr. Indranil Datta. Sir doesn't need introduction, but to formally introduce him, he is the winner of probably the largest number of awards at such a young age. To just name a few, the Shan Ratnam Eofog Award from Asia Oceania 2017, Foxy Dr. Shanti Yadav Award in Infertility 2019, the Prabhavati Dikshit Scholarship in 2019, the Kamini Rao Yuva Foxy Orator 2016-17, Praveen Mehta Fellowship Award, and the list is endless. We are delighted to have Indranil back with us. I think a couple of months back we had a little scare because he was exposed to patients with COVID, and we are really happy to see him hale and hearty. We welcome Dr. Indranil Datta. Next slide,
Thank
please.
you.
We are privileged to have with us Dr. Pooja Bandekar, the Nightingale of the Mumbai Society. It seems like forever since we've heard her sing, but today she is here in a different role. She's here as professor and unit head of the Wadia Maternity Hospital. We also have the dubious distinction of coming from the same postgraduate teacher, Dr. Kaizad Damania. And whenever I see Pooja, I always remember Wadia and Dr. Damania. So thank you, Dr. Pooja, for joining us. Her other extracurricular activities and distinctions are mentioned on the slide for your reference. And if you ever need somebody who's a playback singer to sing at any of your conferences, to do a Ganesh Vandana, she's the first person. She's always there uppermost in our minds whenever we do any academic event at the Mumbai Society. Next slide, please. Dr. Biswajyoti Guha is a friend and a senior obstetrician from AMRI Hospital in Mukundapur. Sir is the council member of the AICC RCOG East Zone. He's also the joint secretary of the Bengal Society of OBGYN, secretary of the ISOPAP Kolkata chapter, and very uniquely, he's been a clinical examination for the MRCOG Part 3 since it started being conducted in India. We welcome Dr. Biswajyoti. All the
Thank
questions
you.
regarding RCOG guidelines and up-to-date evidence will be directed at him. My job is done. I don't need to say anything because I have such wonderful and
Thank,
eminent senior people as my panel.
thank you, Dr. Tambe. Thank you very much for your kind introduction.
Next slide, please. Dr. Tabassum Dalla is the secretary of the Raipur OBGYN Society, and she also possesses a diploma in minimal access surgery. She's a consultant OBGYN at the Jubesta Hospital, as I said, in Raipur. She's trained in assisted reproduction, advanced obstetrics, and gynec ultrasound. She's received the Women Empowerment Award by the Go India Foundation and the Nari Shakti Samman presented by Jaya Prada. Her special interest is in high risk pregnancy, and we are delighted to welcome Dr. Tabassum to this panel. Next slide, please. Dr. Gitendra Sharma, to introduce in one single sentence, is the Vice President elect of FOXY. And after a brief break, after his hectic election campaign tour, he is back with us. We are really happy to welcome a medical legal expert of his caliber. In the past, he's been the president of the Ahmedabad Society, and he's done his LLB with 15 gold medals and topped the Gujarat University. Thank you very much for joining us, sir. And Shrimon, I think that's the end of the introductions. If I may just share my slides, please bear with me for 5 seconds while I do that.
Dr. Pratik, I am also here.
1 second.
Part of
While
panel.
Dr. Bharti
Yeah.
Maheshwari is not there in the slide.
No issue, but you just said like that.
No, I think that was a mistake. Shrimon, I
No
think
issue.
you need to correct that. Dr. Bharti Maheshwari is the chairperson of the MTP committee of FOXY, and I think for some reason her slide has got missed. She is also the president of the Merit OBGYN Society. She's done fantastic work in the field of MTP and for reaching small societies. She's traveled physically. She was a co-chairperson with me, and I remember how much hard work she had put in all her activities. It's lovely to have Dr. Bharti Maheshwari with us. That's all right, Shriman. That's okay. Let's go on to the panel. Are the slides visible?
Yes, it is visible.
Okay, fantastic. So I like to start this panel with an age-old quote. This is by a former TOG president, Professor Mahmoud Fatala from Egypt, and many of you may have heard this earlier. He said that women are not dying because of diseases which we cannot treat. They are dying because societies have yet to make the decision that their lives are worth sharing. This is a particularly poignant way to start a panel, especially on obstetric hemorrhage, because we've seen all those movies in the 70s where women die in childbirth because of postpartum hemorrhage, and then the obstetrician comes out and says, I could save only one of them, so I managed to save the child. Unfortunately, we have lost the mother. I hope we never have to go through such a scenario again at any point in our life. This is the basic structure of our panel. We look at the scientific evidence, we talk about guidelines from international bodies, and then we invite all the experts to give their own personal experience, and we look at the evidence and experience together in practical case based scenarios. So let's start with some basic, simple foundation. Is it really important to talk about postpartum hemorrhage? We are now almost 4 or 5 decades away from those classic 70s Hindi movies when women used to die in childbirth. Is this something which is common today in 2020? Should we be making a hue and cry about it? Is it just for some political reasons because I am contesting for some public office or an election that I'm talking about PPH? Or is it a practical and important issue which all of us should be vigilant about and which all of us should be thinking about? Let's start with Dr. Bharti Maheshwari, ma'am.
Thank you, Dr. Pratik, for organizing this wonderful webinar and topic. So, of course, obstetric hemorrhage is still very much common, and we remember that for last 20, 30 years when we were students, it was the priority subjects, and still today when we are professor and we are teaching our students, still we are doing the PPH drills and all. So, yes, of course, it is genuinely, still we have a commonest cause of maternal mortality is hemorrhage. Yes.
So PPH is still very much an issue no matter where you practice, no matter how well developed your country may be, whether you practice in a tertiary care institution or you're in a primary health center or in a district hospital, you may be a professor and head, but at the end of the day, vicarious responsibility still falls to us. Dr. Tabassum Dalla, what is your experience? In Raipur and Chhattisgarh, I'm pretty sure there must be a lot of inaccessible areas and Mufassal areas where healthcare is not penetrated. Do you see a lot of PPH even today?
Yes, definitely. The PPH is very rampant, especially in places where we don't have good medical facilities. So, in medical colleges, we face around 4% patient have PPH, and then during cesarean, we may have around 6% of PPH. 6% patient may have PPH. But the problem of accessibility is very important because deeper places like Bastar and all have less accessibility to medical care facility, and definitely the mothers are still dying.
So I think that just highlights the great disparity that we have in a country like India, that even in 2020, when we expect that universal healthcare should be there, 100% antenatal registration should be the norm, and that healthcare facility, especially accident and emergency services, should be available to every single woman. This is sadly not happening even today. If you look at the global figures, there is a 3% mortality rate from PPH, and it contributes to nearly 1 lakh deaths. And you can see the figures. Obviously, they are going to be much higher in countries where healthcare is substandard. There are a lot of guidelines which have come in from international bodies, and I'm going to quickly enumerate some of them. This is the WHO guideline from 2012. There's also an RCOG guideline, which is a Green Top guideline published in December of 2016. And of course, there are several other regional bodies, including FOXI, as well as different regional bodies all over the world who have come out with their own guidelines. So to start the ball rolling regarding the practical issues, I'm going to ask Dr. Pranjal Sharma, madam, do you think that it is possible for us to identify which patient is going to go into PPH? Are there some high risk factors which can enable us to triage these patients before they actually go into PPH? Or is it that we don't have any control, that any patient can land up in PPH at any time and we should observe universal vigilance for all these?
Certainly. PPH is not always, we can say that PPH is totally avoidable always, but certainly if certainly we can prevent or reduce the incidence and the magnitude of PPH by prior identification of a patient, by prior identification of the patients who are prone for PPH. So for any patient, yes, we have to be prepared for, like we know that there are certain factors which are like pre-runners for PPH. So we have to be our eyes, and we should be tuned to catch up those patients in our routine OPD, and high risk remark should be written at the top of their cards. Like for example, the age criteria. If the patient is elderly, so she is more prone for the PPH. Then if the patient has got BMI more than 35, she is more prone for PPH. If patient has multiple surgeries or previous 2 or more sections or any like myomectomy or this kind of thing, she is more prone for PPH. Over distension of the uterus due to multiple pregnancies or hydroamnios, she's there also she can lead to PPH. Another important thing which is the medication. Sometimes there are some medication which, for example, if we are starting the oxytocin for induction of the labor, yes, the incidence of the PPH is more, and we have to continue the drip after 1 hour for controlling that PPH. So pre-runner for PPH should be well thought of in advance, and we have to that itself reduces the burden a lot. It is.
Thank you. Thank you. Dr. Indranil Datta, sir, would you like to further this discussion by talking about the 4 T's? We always start by talking about the 4 T's, and whenever we teach our juniors and residents, this is something which is drilled into their heads by us because it was drilled into our heads by our professors. Please, can you tell us?
So before going into the 4 T's, one thing I would like to tell, the commonest problem which our women face is anemia. So anemia is the first thing you have to look at in our patient, particularly our Indian population, because if the patient is anemic, invariably they can go for postpartum hemorrhage. Then coming to the factors which we actually deal with in our post graduation teaching is the 4 T's. That is the tone. So any cause, anything which over distance the uterus, or basically any sort of multiple gestation, multiple pregnancies, any uterine malformations, uterine anomalies can lead to the defect in the tonicity. Okay, then any sort of tissue, like any retained products, like previously the patient would have had some surgery or any existing any pathologies within any sort of basically the trauma. When we come to the trauma section, because we are dealing with the risk factors here. So trauma means any malposition of the fetus, any previous uterine surgeries, like as mentioned by madam, like myomectomies or previous cases of uterine ruptures. And lastly, coming to the thrombin, which is the most important part, any sort of congenital disorders like problems like von Willebrand disease, like hemophilia A or purpura, all these can lead to postpartum hemorrhage. These are the accepted like book terminologies which should be put in our mind and our postgraduates' mind. But obviously, coming back to the basic problem in our country, anemia, PIH, any long-standing, any renal disorders, all these and any sort of sepsis history even should be considered as a high-risk factor for our women in our population.
Thank you, sir. Dr. Pooja, as a unit head in a tertiary care institution, what is your view that if we had maybe universal or 100% antenatal registration, would we be able to pick up many of these issues much earlier so that we are able to identify these things, we are able to give patients a high risk status, and then appropriate interventions can be staged so that we don't have to run around, call for help, and run like headless chickens when the PPH actually happens? What is your view on this?
Sir, my view is that if we have a timely antenatal registration, then definitely we can ensure the antenatal health of our women. As Dr. Datta has rightly said, anemia and malnutrition is one of the important reasons of postpartum hemorrhage in our country, and it is something which is preventable. We all know it, but somehow, because of the compliance of patients, because of the cooperation that they get from their family, because of their own work pressures, because of no spacing or less spacing between births, these problems are not tackled. And in spite of registration, another important problem that we face is regular compliance and follow-ups of the patients. So if we have a good antenatal registration, if a thorough antenatal registration happens, then we can ensure the antenatal health of the patient. But I would definitely like to put forth one important point as a unit head difficulty which I have faced is Any lady can have a PPH. It is so difficult to predict. And the second problem that I have witnessed in PPH is that there is late recognition of the problem. Because initially, although the lady bleeds, she is able to compensate well. So her vitals don't deteriorate that fast. And when they start deteriorating, that is the stage when all her compensations have failed. So she deteriorates just like that. And in an institute, what happens is intern tells a houseman tells a registrar tells a lecturer tells a unit head. Until then, it's all gone, it's out of control. So I feel that PPH is one thing which you have to keep in mind during each and every delivery. During the babies coming out and during the expulsion of the placenta, you cannot leave the patient alone. Your mind has to be on the guard. And the minute you see that there is something different happening, you start managing, but call for help. And don't look at hierarchy at that time. Call for competent help, person who can help you deal with the situation. I feel that will definitely help us reduce probably the incidence of PPH.
Thank you so much. I think this is the perfect point to bring in Dr. Biswajyoti sir. Sir, how would you highlight the importance of skill drills and regular training so that we all function as a united team and we don't run around like headless chickens when there is an emergency? Sir, I think you're muted, please.
Thank you, Dr. Tambe, for inviting me into this very unique discussion of yours. I think this is one of the very important aspects of our practice. And as you mentioned that you wanted to know basically what would how would you anticipate, and if I get your question correctly, because there was a little bit of hearing problem, can you please repeat your question?
Obstetric skill drills. Obstetric
Yeah, skills drills, exactly. So skills drills is very important because we all know that when a PPH doesn't come like it's a bolt from the blue. If you are already prepared for a PPH to happen, then you are ready. You have your bloods in hand, you have your lines in place, you have your 14G cannulas all in place, you have your you have your senior backup well in place. But when it happens suddenly, for example, if you are having a normal delivery and suddenly the patient starts hemorrhaging, this is a unique circumstance where your brain will not work. But here you need a teamwork to act in perfect cohesion with a good timing. And to enhance this skill, you must have regular skills and drills. As I think Dr. Maheshwari mentioned that even nowadays, even in this age, in this 21st century, skills and drills is very important because timing and your cohesion, your cohesive force is what is going to save the patient. So that is very important together with the timing.
Thank you, sir. I think it goes without saying that all
as
of us.
Dr. Datta mentioned.
Yes, sir. Please go ahead.
Sorry, there is a little bit of a network disturbance going on in my area, but so the main thing is that about skills and drills is that if we can continue it, if not only the juniors, the seniors get involved in the skills and drills, and the juniors get involved in the skills and drills, then we can
I think we've lost, sir. There's some technical issues. So I'll just quickly close this discussion by saying that uterine atony happens in up to 80% of patients, and this is the main factor which leads to PPH. That entire big laundry list which you saw is only for theoretical purposes. That is when you want to dot your I's, cross your T's, and answer in an exam. In practice, the vast majority of patients are going to present with uterine atony. Nobody comes with a sticker on her forehead saying, I'm going to have atonic PPH. And therefore, universal precautions, importance of functioning as a unit all together, even in times of emergency when your brains are not functioning, that is of paramount importance. And each person in the team needs to have a clear designated role. So let's talk a little bit about what happened by the ACOG publications which have come out in 2019. they've tried to identify some important factors and come up with these risk assessment tables. The Americans always like to do a lot of statistics, give you checklists. So this is one of the checklists. If it's something which contributes to your learning and helps you to teach your postgraduates, I highly recommend this to you. This is by the Safe Motherhood Initiative from the American College in 2019. Yet another thing which you can add to your armamentarium. But again, I'm going to underscore this important sentence that 80% of causes of PPH are because of atonicity. And atonicity is something which cannot be predicted. All the other identifiable factors we have already talked about. Let's quickly move to the choice of what is the drug if you want to prevent PPH, or what we call active management of third stage of labor. I've given the game away by talking about it directly, but you all know the answer. It's important to dot the I's and cross the T's and not only talk about management of a condition when it happens, but also equally important to focus on the prevention aspect. And I'd like to ask Dr. Pranjal Sharma, what is it that you use in your practice? Has it changed over a period of time, or you've used the same thing over the past 20, 30 years?
Yes, there are certainly. This is very like you have added that in last 25 years. Is there any change? So that is very important. We were like, it is very unfair to quote any single drug or give importance to any single drug as a uterotonic. So we have to have our full basket of the drugs and timely using those drugs one over the other. In particular case, we have to sort to. So previously, before say 15 to 20 years, we were dependent quite a lot on the oxytocin, where like oxytocin drips and injection ergometrines were the things to rescue. But as the time period, like we are lucky to have now injections like injection carboprost in our armamentarium and prostaglandin E2s, misoprostol, etc. And things like those which take care of fibrinolysis like tranexamic acid. So this full basket we are lucky to have now, but certainly we have to decide it case wise.
Thank you, ma'am. So I think the choice of uterotonic agent for prophylaxis, what is recommended by WHO, has been oxytocin. We may or may not always use oxytocin because some of us are afraid that oxytocin, when given as a bolus, may land up with issues. So some people tend to prefer methyl ergometrin. Professor Datta, what is your choice? Would you prefer oxytocin or methyl ergometrin?
So it is always oxytocin. Just put oxytocin in the drip, or you put it IM, no problem. And I always am from last 1 year of my practice, I am adding tranexamic acid also. As soon as the delivery of the baby is there, just add the tranexamic acid and just be safe. And but sir, I'll like to add one more point because I go to very distant, almost Bangladesh borders to practice, and I keep traveling with misoprostol tablets.
Yes.
So I give it.
I was waiting for
also.
somebody to say that. Please go ahead. Yeah. Sorry, I interrupted.
So it has to be kept with you. As I am hypertensive, I carry my Stamlo. I carry the misoprostol for the patients also along with me. So that has to be in your hand. But yes, oxytocin and tranexamic acid should be the first choice.
Hopefully, you don't get those two mixed up in your pocket. Huh? Dr. Tabassum, you practice in an area where there are a lot of patients who are coming from, smaller inner cities or inner towns, villages, where proper obstetric care is not available. Maybe they are referred from a primary health center. Do you think that this is something which would help to save a lot of women before they are dispatched from a periphery? Do you think that this misoprostol, which is recommended by WHO, can be a life-saving drug? What do you feel?
Definitely, misoprostol would be life-saving drug because even oxytocin will, prostaglandins, otherwise it's very difficult to maintain. And the cold chain maintenance is important, which cannot be maintained in small settings and places where even a fridge facility, refrigerator facility is not available. So misoprostol in that sense is a wonder drug, a life-saving drug, definitely. Single misoprostol tablet can be kept in a pocket. A dai can keep that and she can use that appropriately whenever it is needed. The only problem with it is maybe they may misuse it. But if properly trained and properly explained, then misoprostol can definitely save lives and save mothers.
Dr. Pooja, question for you, leading question and direct question. Oral or per rectal misoprostol? Which would you prefer?
Correct.
Per rectal. Unanimous for all the panelists?
Yes.
Per rectal. It's very easy to administer and it's very quick, and you don't have to contend with the vomiting and the other absorption issues which are there. And within 10 minutes, you would see the results. I'm still on the phase of prophylaxis, and this is from the WHO guideline. Controlled cord traction. What does the panel feel about this? Bharti madam, I'm sure you must have attended many calls where your residents have pulled on the cord too early and the entire uterus has come out. What is your experience? Do you recommend controlled cord traction, or do you think that it should be outlawed and banned?
No, Dr. Pratik, I never attended call when my resident has pulled it. Actually, from MBBS time, and we are very much particular about training the student. Even MBBS final year student from my college cannot pass without knowing the active management of third stage of labor. And according to WHO protocol and contraception in lactational period, that is the two thing without that MBBS final student cannot pass. And the first year residents, as they come us, we properly continue to do the training protocol, especially for PPH, even though it is so common and it is so we know much about it, but continuously we revision trainings, drills and all. And in that, the active management of third stage of labor, oxytocin 10 units, that is at the anti-estrogen delivery. And besides, of course, misoprostol can be used per rectal whenever it is required. Second thing, control contraction. They are very well trained. We have lots of videos. We have, my resident cannot say that it is done. And third thing, that uterine massage. So these are the regular protocols we train, and even Asha A&M are, we are in I am a professor in a medical college, tertiary center. So I have lots of exposure of district hospitals, some periphery centers, PSC, CSC surrounding, and they bring the patients, refer patients to us. So even Asha A&M trained attendants, we always try to train them, and we recommend that this controlled cord traction should be trained and this practice should be relevant.
Perfect. So I think she's underscored the importance of not yielding to temptation and trying to avoid controlled cord traction, because this is something which can land up with a lot of complications and problems, and they may be very quickly difficult to manage. Gitendra Sharma sir, you are here. I think you've joined us. I saw you briefly. Welcome to the panel, sir. Thank you so much for joining us. Can you tell us little bit about this cord clamping? आजकल बोलते कि cord clamping थोड़ा लेट करना चाहिए, तो normal delivery में भी लेट करना चाहिए, cesarean में भी लेट करना चाहिए, या अपना regular timing पे करना चाहिए? What is this late cord clamping? कितना लेट? 10 मिनट रुकना चाहिए, 5 मिनट रुकना चाहिए, क्या है ये सब?
Sir, actually, I am no more obstetrician, so but I will definitely like to answer that. A little bit, you have to little bit wait for cord clamping. So 1 to 3 minute time after delivery, you should clamp the cord. So that will be advisable in normal delivery cases.
Thank you, sir. Dr. Pranjal Sharma, this has changed a lot over the past 20 years. Earlier, we used to do immediate cord clamping. Aajkal the pediatricians are saying wait for a little while. But do you think that this increases the incidence of hyperbilirubinemia and neonatal jaundice? Have you seen that in your practice?
Actually, the delayed cord clamping should be strongly practiced. We should delay even in normal delivery or in cesarean section. As I have my baby unit or my husband is pediatrician, I get the follow-up routinely. Delayed cord clamping is, there is no quite like there is no difference between the hyperbilirubinemia. Rather, these babies are having good hemoglobin, and if we are not storing their cord blood, then at least give that blood to this baby. And there are many studies who confirm that delayed cord clamping must be performed, and we go with only there are in two or three conditions, like if the baby is asphyxiated, we have to immediately cut the cord. One thing. Another thing is that if patient is bleeding without separation of the placenta, then we have to take care that we are supposed to debulk the uterus as early as possible. In that case, we can cut the cord and give the baby to the pediatrician, and rest of the manure we can go with.
I see Dr. Biswajyoti Goa is back with us. I think sir, we lost you because of internet issues. What is your take on this entire delayed early cord clamping issue? Do you?
I think there is. I think, Dr. Tambe, there is no controversy regarding cord clamping. It has to be delayed by 1 minute. That is the recommendation because it increases the amount of blood flow. The baby does well, and only in certain circumstances where it is indicated to have a, if it's RH incompatibility or things like that, where you need to clamp early, then it is indicated. But otherwise, delayed clamping should be the norm. That is one. And I think I missed on that oral misoprostol and the pararectal misoprostol. I just want to add one thing,
Yes,
Dr.
sir, please go.
Tambe. If the
Yes, sir.
patient is on the table and she is hemorrhaging and you are doing a cesarean section, in those cases, a few of those which I had faced I asked my anesthetist to just dissolve the misoprostol 800 milligram and put it sublingually. And believe you in me, this works like magic. Because when she's having a cesarean section, it's very difficult to insert per rectal in a hemorrhaging situation. But if you have some misoprostol and put it sublingually, then it works very well. So if it is oral, I will not give oral. I will always give per rectal. But if I have the option of giving it sublingually, maybe that can help also.
So that's a new practice point for all of us, and I assume that the patient is under regional or spinal anesthesia and she's awake to avoid the risk of aspiration. And that's
Of
a very
course.
good point. Thank you very much for bringing that up, sir. We've talked about the uterine massage already and cesarean section also. Let's quickly go to the cases, and we'll start with Dr. Pooja. This is a 27-year-old primigravida. She has a booked delivery, uneventful pregnancy, regular visits, went into spontaneous labor. Baby has delivered 3.2 kilos 30 minutes ago. Placenta is still stuck inside. There's about 750 ml of blood loss. And I'm asking this question to you because you brought up this issue of going up the chain of command. And by the time the head of unit is informed, even if he or she is on the premises and can be there within 30 seconds, by the time it gets kicked up to the HOD, it may be 1 or 2 hours later. Please tell us, what should we be doing in this particular clinical situation?
In this, this looks like a case of a normal primigravid who has had a retained placenta. So we will have to look into the vitals of the patient, stabilize the vitals of the patient, replace if whatever blood she has lost, and at the same time look at the cause of bleeding. And if it is at retained placenta, then we need to understand whether this placenta is separated or no, one, and secondly, whether the cervix is closed down or is it still open. So I would either examine this patient in the labor room, but if I feel that my backup and my lighting facility is better in the operation theater, I would rush her to the OT. When I get the call, I'll ask them to shift her to the OT. I'll come in the OT and I'll examine her in good light, in dorsal lithotomy position. First step, as my boss, Dr. Damani, always used to tell me, would be emptying of the bladder. So that helps me maintain the anteversion, anti-flexion. At the same time, it also helps me to understand vitals of the patient because it is giving me an idea of the urine output, which is telling me about the hydration of the patient and the renal functioning of the patient. So after emptying the bladder, I'll do a thorough inspection. First of the perineum. All this has to be done in seconds, although I'm telling in steps. I'll look at the perineum. If there are any lacerations, cuts, traumas outside. If no, next is the vagina. If vagina is showing any lacerations, extensions, then the next look will be at the cervix. If it is open, if it is closed. If I can see an open cervix, I can see a placenta still then with the cord dangling out. Then a quick ultrasound to see if the placenta is separated or no. And if the placenta is separated, then my step is only to get the placenta out. If it is not separated, then I need to understand whether there is a plane of separation. If there is a plane, then go ahead with the separation. If there is no plane, I know that I'm probably dealing with a morbidly adherent placenta and then work on those lines.
So we'll come to morbidly adherent placenta a little later, but I think she's covered it very beautifully. Professor Indranil, sir, anything else you would like to add?
No, sir, it's correctly covered. Only one thing I can add is if
Yes,
I am
sir.
at the delivery table and I am the junior and I have to call someone, better I would, when we are checking for the placenta, because if we wait too much, the cervix will close down. And if the placenta is partially separated also, I think I'll try for manual removal if it has separated a bit over there. And if it
Would you
doesn't
do
work,
that in the labor room or would you wait for the
yeah,
patient to be
labor
shifted
room.
to the OT?
If I am delivering the patient in the labor room
Yes.
itself, I am talking when I am the delivering person.
Dr. Tambe, Dr. Datta has rightly said that you need to, if the patient has got a partial separation of the placenta, and then it will be better to go for a controlled cord traction probably, but not a manual removal in the labor room, because if we do a manual removal in the labor room with the patient awake, then there is a high chance that that this patient might have a
Vagal syncope.
vessel syncope. So it will be better for her to go into theater under general anesthesia or a spinal anesthesia, whichever might be. But that will be a best way to manually remove the placenta
Yeah,
rather than do
sir,
it in the
correct.
labor room.
So
Yeah,
often what will
correctly said,
happen.
sir. But only in the condition where it is almost separated. Sometimes it just hangs above the cervix, so you have to just remove it from there.
Perfect. What happens is that the cervix sometimes prematurely closes, and
Yeah,
Yes,
placenta
exactly.
has already separated, as you can see from the signs of separation, the gush of blood, the bubbles, everything that is classically described in the textbooks. In those situations, probably I would agree with Dr. Indranil. Maybe it's wise to take that course. But in all other patients where you're suspecting that the
yeah.
placenta is only partially separated or not separated, it's always wiser to move her in the theater, as Dr. Pooja said, good light, good anesthesia, good assistant, and ensure that you have two large IV bore cannulae. Make sure that the entire team is activated, and then under anesthesia, you go ahead and explore and perform a manual removal if it is necessary. Now, the practical scenario is like this: by the time you are informed and you are the boss and you are the person who is going to perform the actual procedure, by the time you arrive on the scene, either the patient is totally moribund in shock, or it may happen that the placenta is just waiting there for you like a good morning appendix, and you will just come out and you will become the hero of their day. It can be
Yeah.
two extremes.
Yes.
Usually it is
Yes.
nothing
Yes.
in between. From personal experience, I'm sure all of us have had that experience. When we are dealing with these issues and we are scared, and we are working at a spinal level, it's usually at these two extremes. Either it's badly stuck and you really are going to face a lot of difficulty, or by the time you arrive, you're just going to do a simple removal which happens in maybe 30 seconds, 1 minute, and then that's it. And the rest is just fluid and resuscitative measures that we are going to do. For the obstetric hemorrhage, there's a checklist. Again, this covers a lot of things that we have discussed already. This just puts things back systematically. And as we said rightly, that often all that is required is for us to put systems in place where each person on the team does this stepwise in a systematic fashion. But as Pooja again rightly mentioned, this has to be done simultaneously. It may take you 10 minutes to recite all the steps, but in practice, everything has to be executed simultaneously in a matter of 2 or 3 minutes. I'm going to bring Dr. Geetendra Sharma sir back into the discussion and tell us what is the importance of this documentation and this checklist. ये सब करना क्यों जरूरी है? What is the importance from the practical and medical legal point of view?
Basically, whenever a case is filed against doctor in any court of law, the doctor comes to us and they explain very nicely that, sir, when this PPH occurred, we did this, we did that. So step by step explained. But when we ask for the documents and see the documents, nothing is mentioned in the documents. And the problem in court is that court runs with the document, evidences. So courts are the courts of evidences. They are not actually doing the justice, but looking to the evidences, they give their decision. And when they look to the document, and if nothing is properly mentioned in the document, then case is going to be decided, even though there is no negligence on the part of doctor in treatment. But even then, the case will be decided against the doctor. So documentation is the only thing available to you in your defense in the court of law. And that's why, whether you have done it or not, but document it properly. That is the advice.
If it is not mentioned on the paper with date, time, and your signature, it did not happen. Whether or not you say so,
Yeah.
because what is documentary evidence, that is the only evidence that will help you and save you, God forbid, if it ever goes to a court of law. That is the take home message for everybody. This is just a quick mnemonic for those of us who are in teaching, and it's a very nice mnemonic called hemostasis. Ask for help, assess and resuscitate, establish etiology, massage uterus, O for
And
oxytocin,
sir, can
X
I
for
get
shift
one
to
more
theater.
point as you're running through your list?
Yes, ma'am.
Pratika? Yeah, I just wanted to mention one little thing which I thought is significant. Again, I have learned it from Damania sir, that whilst we are doing all this, whilst we are shifting the patient, while we are working on the patient, there has to be one responsible person who is counseling the relatives and who is communicating or at least updating grossly about what is happening inside.
True.
So
We'll
that
come
the
to the
relatives
issue of
also understand.
communication with the relatives, the entire unit, and breaking bad news and all that. In fact, we have a medical legal expert here on the panel just for that, and we'll come
Dr.
to that
Tambe, sir,
a little later.
just
Yes, ma'am. Yes, ma'am.
can I interrupt? Just a small addition.
Sure.
Everything very well explained by all esteemed panelists. Just a small thing which I am practicing since last some years. There is something called as a max estimated allowable blood loss, maximum estimated allowable blood loss. So usually the Android phone, the Play Store of the Android phone, it has this app. So we can download this app. It has got a very simple formula. When a patient is registered, and if she's like during at term in 9 months, we all get her CBC done. So we are having the readings of her hemoglobin and PCV with us. So if we have worked out on this formula, which is current PCV minus optimal PCV upon current PCV multiplied by the blood volume, which is roughly 4.5 to 5 liter. If we calculate it, so we get a figure like if the patient is having her hemoglobin around 12. So her calculated maximum allowable blood loss will come to around 1 to 1.2 liter. So if that patient bleeds that much, so we should have that figure noted on front part of our card. This much is her allowable maximum blood loss. So if it is there, so we can definitely sort out the patient. If the same patient is having 8 gram hemoglobin, and if we have worked on the formula of that maximum allowable blood loss, so we know that if this patient bleeds even 400 ml, which is not a PPH by definition, but it is still more for that patient, and the chances that that patient can go for shock are more. So we have to take the cognizance, or we have to start practicing applying this maximum allowable blood loss formula in our practice. So
Good
that is
point,
a
ma'am.
small
That's
addition.
a very excellent point. I don't know whether we should document it on the paper, however, because that can be held against us, but we can always make a mental note. And as
Mental note
we have
of it.
already said it several times, that anemia, which is prevalent and we so often ignore it, we just brush it under the carpet saying that anemia is something which is routine.
True.
क्या CME में बोलने का anemia. But that is probably one of the number one most important issues which is very widely prevalent. I want to ask Dr. Bharti Maheshwari ma'am, what is your choice of IV infusion? Should it be crystalloid? Should it be colloid? Should it be a combination of both? And when do you make the decision to switch?
Yes, Dr. Pratik, this is a very important issue, fluid management. As Pooja has said, that as the patients come in, whenever there is a hemorrhage, we always, before that, we of course anticipate all these things where these facilities are there. But in the first line, I would like to do crystalloid, mainly ringer lactate or normal saline. And then we monitor the patients by the vitals and all. And if there is a hemorrhage, and then we arrange for the blood transfusion by cross matching and all. So my preference is the crystalloid.
Okay, Dr. Indranil sir, any change or would you concur?
No, that's what Madam has told is absolutely correct.
Absolutely correct. So when you start off, you may not have colloid readily available. So you collect your blood group, cross match, make sure that you have a sample collected. Because if you start off with colloid and then later on you will face difficulties for the cross match. This is just by the by, I'm putting it up. A NATA guideline or a consensus statement. This is the North American Association for Transfusion Medicine, and this is regarding patient blood management and obstetrics, freely available on the internet. It gives you, this is actually an organization of hematologists, which tells you step by step how much fluid to replace, which should be the preferred fluid, when should you give blood, what is the type of blood you give, and so on and so forth, beyond the scope of today's discussion to discuss it in detail. But it's always good to know that there is more evidence which is coming out regarding fluid management and which type of colloid or crystalloid you should use, how much to be used. We've already seen the excerpt from the RCOG guideline. We've talked about retained placenta. We've covered all the important issues. We've also said what are the drugs to be administered. We've talked about the management in the OT and when would you actually try and ensure that you make sure that this is going to minimize the time taken to deliver the placenta. The next steps are going to be very quick. External aortic compression. Dr. Biswajyoti, any experience? Do you think this is important?
Is Dr. Tambe, I don't have any such experience of external aortic compression except in one circumstance where we had an unfortunate incident where a patient came in with a ruptured uterus, having been involved in a road traffic accident, and the baby was already dead, and she was about to die. So we had to put and I think that there was an injury blunt. There was also an injury on the inferior vena cava, as far as I remember. It was not in this country, and we had to. I and one of my colleagues had to an emergency medical officer there. We put a fist on the abdominal aorta and and just kept it there until help arrived. And this lady was barely saved. I think she went home but had a protracted recovery. I mean, she probably lost her vision and became deaf later on in life. But that was only one incident where I had to had an aortic compression. But otherwise, in severe PPAs that we encounter, I think I have never had had an instance where I had to had to put an aortic compression.
So
I
if
indeed
you're a
had to
junior
do.
resident and you're dealing with a very thin, lean patient who is bleeding, probably this is one of the measures
One
that
of
could
the
be
major,
adopted.
yes, it
But
could be.
probably not practical for most of our patients because they're all quite hefty and well built. Crystalloid and colloid we've already covered. Tranexamic acid somebody has already mentioned, but just for the
Dr.
sake of repetition.
Dr. Tambe, can I
Yes,
just
sir.
mention about this
Yes, sir.
crystalloid thing? Crystalloid has to be, Dr. Maheshwari exactly say that, the crystalloid has to be infused. It has to be warmed up crystalloids, because if it is cold crystalloids, then it sometimes can cause more shivering in the patient. So if you have the facilities of warming up the crystalloid very quickly, that would be very good. That is one thing. And the second thing that is very helpful in this kind of circumstances is somebody writing up, somebody just writing down the amount of fluid going in, because in the zeal of managing the PPH, we sometimes, and when we have two 14G cannulas rapidly infusing, sometimes these patients you can over infuse. So somebody just needs to just write down the amount of fluid going in. That is also very important.
Dr. Pratik, just
Yes,
want to add something about aortic compression.
Sure.
This is what I have experienced, and I know that external aortic compression is a one important measure, and sometimes it is required, and we should be aware of this thing, and anti-shock garment also, because as I have said that in the PPH we get something new and by experience and documentation. So these are the two things which we are trying to bring in our practice. As the patient comes in the postpartum hemorrhage, when he has bled a lot, then first thing what anti-shock garment and then external aortic compression. It actually works if it is possible, that you just have to keep your fist on just above the umbilical. And in fact, Dr. P.K. Shah, I remember in around 7-8 years back when he was the president, he come to our society and he demonstrated. And many of us, so actually, whether it is required or not, because it is not only measure which will prevent the PPH or it will control, but definitely we should be aware that it can work. So we should use, because there is no harm
at
in
a
using.
primary health center level, I think pneumatic anti-shock
We can till we are shifting the patient and we are arranging the help and all. Yeah.
Absolutely correct. Dr.
Rather
Pranjal
in
Sharma,
our-
madam. Yes.
Rather in our Lakshya Manyata program, this maneuver is being taught to the paramedic staffs as well. And yes, and it is very nicely elaborated in that book.
So since we are with Dr. Pranjal Sharma, madam, I wanted to ask you if the time has now come to make tranexamic acid administration prophylactically universal for all deliveries, whether vaginal, whether normal, whether high risk, whether cesarean. Would you agree?
Not universally. Personally, I would not agree universally. But yes, in certain cases, there are the cases who are pre-runner for PPH. I would certainly like to, and we are practicing it also. It is very good anti-thrombolytic agent. In cases of like previous cesarean or in cases of hypertensive disorders of pregnancy, or patient if already she is anemic, I would after my pre-medication for cesarean, in case of cesarean, I will start a drip of set 1 gram of tranexamic acid to this patient. Even in normal delivery, if the patient or tissues are oozing, it is rightly to use the tranexamic acid. So it is in certain cases, but not in all cases I would go for.
Dr. Pratik, I know about the tranexamic acid, that though it is my very favorite drug in the gynae and all hemostatic as a user, but I have known that when fetus is inside, so if we should use it cautiously because it crossed the placenta, but otherwise, after delivery, you can use it. It is a very good drug whenever it is required.
Also,
Absolutely.
WHO now has in 2020 September, it has come with the guidelines where there are recommendation for tranexamic acid. And
Exactly, Dr.
Kiran
Prajal. I
Kurtapati has
think
also mentioned it in
I
his
think
talk. Yes, sir,
Dr.
please go.
I think there was a paper published in NEGM and then WHO came out with this guideline that 1 gram of tranexamic acid just after induction in suspected where you are anticipating PPH is a good method to
Prevention.
what it does, it minimizes the risk of blood transfusion. It does not prevent the PPH, but it minimizes the risk of blood transfusion. That is what it has been found out. Yeah.
Thank you. I think we've covered the other issues already. Does anybody have any idea what is this obstetric shock index? Question is open to everybody. Please feel free to go ahead. Have you encountered this term earlier, obstetric shock index? So it's the systolic pressure divided by the pulse of the patient, and anytime if it is more than 1, then it is supposed to be an issue. We've already covered pneumatic anti-shock garment. What about intrauterine packing, the Shifker pack and the balloon tamponade? Datta sir, any experience, especially in periphery, with utilizing these rare conditions?
Yeah, only thing which we have used is the condom balloon catheter. Only thing which we have used, and it works really well. Otherwise, the other ones, the typical book songs, I have not used.
But
So,
when you have to use it in a pinch, you found that it does help and it is a
yeah, it
life-saving.
definitely helps. It is the easiest available option, and it is works really well.
And it's cheap, and it's very cheap also.
Yeah,
Easily
cheap
Yes,
available
yes.
wherever you
Easily
are.
Even we
available.
have used balloon tamponade in our periphery practice, and it works wonders.
We've already covered the pneumatic anti-shock garment. Does anybody have any experience of the vaginal clamp which Dr. Professor Piley talks about? Any experience from anybody?
No.
I have
I don't think
kept
we have anybody from the south on the panel today, unfortunately.
so this
Otherwise, they
vaginal.
would have just.
I was very much lured by this vaginal clamp by Dr. Piley, and I have purchased this 2 years back. But
Fantastic.
fortunately, I did not get opportunity. Fortunately, I did not get opportunity, though I have tried practicing in 1 or 2 patients. But this is one of the good option where you can maintain the maintain the uterine arteries angulated, and theoretically, yes, it can. And Dr. Piley has given the study of 650 patients where he has reduced the maternal mortality, and this he has saved patients from hysterectomy.
This is a good take home for all of us that this is maybe one instrument which we should have in our armamentarium and pray to God that we
Yes.
never have to use it.
Yes,
When
exactly.
you do use it, please don't apply it for more than 20 minutes because there is some incidence of ureteric injury. We will not talk much about that, and let's move quickly to the next case because we are running out of time. This is a 34-year-old Pramegowda. She is conceived on IVF treatment, previously treated for intrauterine adhesions, underwent hysteroscopic adhesiolysis. You can see how the risk factors are piling up with every single point there. She was going to have a cesarean section at 37 weeks electively, but at 35 weeks, she presents to accident and emergency, or RR as we call it in India, with hypovolemic shock. Cardiac activity is present, there's fetal bradycardia. There's no question that she needs an exploratory laparotomy. But then I want somebody to explain to me what are the further steps that you will take in this patient after you've opened her and you've delivered. Dr. Tabassum, you've been quiet for a very long time. Please, let's start the ball rolling with you.
She's already pulseless. Then I would like to do one periportum hysterotomy and remove the baby so that at least we can save the baby. And after that, we can think about the patient because we have to take immediate decisions. And we should ideally keep the patient a little left lateral, and we can keep a wedge inside her towards her right side so that the patient gets tilted. and the ABC should be simultaneously, as Madam had said, that simultaneously we should think about resuscitation as well. So we have to call for help, and all the resuscitative measures should also be taken place as soon as possible. And it's possible that after delivering the baby, the circulation may maintain, the patient may regain, and then if the patient is still bleeding, then we can go for
So let's cut to the chase. This is a question. This is a case of query rupture uterus.
Yes,
What
yes,
kind of
yes,
rupture
yes.
has taken place is impossible to predict. It may be just a
Yeah.
simple fundal rent. It may be a complete rupture where there's an irregular jagged tear involving many areas of the uterus. They may be floating around in the peritoneal cavity. Nightmare scenarios. But here you have to control the bleeding very quickly because the blood will start welling up. The entire cavity actually may be full of blood when you first do your incision into the parietal peritoneum. So here what I want to emphasize is the importance of speed and time. Now, though the textbooks say first you start with a uterine artery ligation, you do a stepwise devascularization, that is all very good for theory. In practice here, when the patient is pulseless, the baby may be stretched for life. Here you need to do an emergency life-saving surgery. What would be your
Yeah.
choice? A hysterectomy?
Yes, of course,
Internal iliac ligation?
No.
Hysterectomy.
Hysterectomy straight.
Hysterectomy, direct.
Straight away. Straight
Correct.
away.
So I think here this is important to make the right decision at the right time in order to save the life of the patient. Dr. Bharti Maheshwari, what are your thoughts on this? Do you agree with what is being said?
Sir, of course, this is time is very important, no doubt about that. We don't go like theory, this. But we all possibilities explore in a second. So whenever we see the open the abdomen, of course, I will definitely see whether there is an option that internal iliac can save the uterus. Definitely, it will come in my mind. But in such cases, that many of us have experienced that we have to do hysterectomy. That is the way. I cannot decide previously in advance that I will do that. What I can say.
So though the textbooks say internal iliac and so on and so forth, and try and save the uterus with a brace suture or a Cho
These
suture
things
and
work.
so on and so
It's
forth.
not like
These are good for atonic PPH.
Yeah.
These may not be ideal in a patient who has a rupture uterus.
Yes.
Absolutely correct. Dr. Biswajyoti sir, what is your view?
I completely agree that when you are entering when you have a patient who is pulseless and does not have a blood pressure, you just want to go in and quickly save the life of the patient. In this case, I think a hysterectomy will be, as Dr. Maheshwari said, we'll probably look into the options, but the most likely option will be probably a hysterectomy, quick hysterectomy. Most likely will be a hysterectomy will be a best option to save her life. So I will probably go in and do a quick hysterectomy rather than wasting any more time on internal iliac artery ligation and compromising the patient's safety.
Dr. Tabe, can I add one more point?
Yes,
Dr. Tabe, I support Dr. Bharti Maheshwari Madam's thought that yes, let us after stabilizing the patient or taking her in OT, just have a look after opening the abdomen. There are even like rupture uterus is not per se always hysterectomy.
Yes.
Can be repairable, and we have like Madam is a professor. She might have done many work in OT, and she knows that many uterus can be saved. There can be a simple range which is bleeding torrentially, but it is at the fundus side. So just suturing the fundus can help arresting her bleed. So we can save the uterus. It's need not if there is a tear on the fundus and she is bleeding from there. What is the need to do the hysterectomy? So it is when we open the abdomen.
It has to be individualized according to the patient.
Individualized,
yes, Professor Indranil.
But in such patients, we may have later on, she may go for a secondary opening up, and we may need to suture or do hysterectomy later on.
Dr. Rida, at that time, because I am an area in the Muzaffarnagar, that is the Western UP, and it's a medical college for 20 years. I am a head of department there, and I have experienced worse and worse case. And for last 20 years, I have seen now there is a lots of improvement. There is a lots of reduction in the inversion, lots of reduction in the rupture, but still we have around 1 or 2 bad rupture uterus we found. So, and many we have repaired and we saved, but it depends what team you have, what you have resources, what your expertization. If you think that hysterectomy you can do better, your team, then you have to do hysterectomy. But if you think you have experience and you think that we should take for the chance, then it's okay.
Yeah, agree
So
with
the
you.
Back to Dr.
idea should
Only
Tabassum.
be,
But
yeah, the idea
session
should be
saving is the
fast.
first.
Yeah, it should
Yeah.
be fast in and fast out. And
Yes,
even
yes.
if we have to go for hysterectomy, I think subtotal will be the best choice in this case. Uh, any light on that one, madam?
Absolutely
Uh,
true that you decide on the spur of the moment when you open the
Yeah,
patient,
yeah.
and you decide as per the condition of the patient. As I said, it may
Yeah,
be just a simple rent in the fundus because she's undergone hysteroscopic
yeah,
Hysteroscopy.
visualizes. It's impossible to predict how much of the uterine
yeah.
cavity is involved. It may be an irregular rent, there may be multiple tears,
Yeah.
baby may be floating around inside, like we said. So it's impossible to say. Only
and
you,
Dr.
once you open the abdomen, will know,
You
and then
can
Will know what to
appropriately
do.
you decide
Yes.
what is to be done.
And Dr. Tambe, another thing is that if you have to go for a hysterectomy, if in this kind of a scenario where the patient is pulseless and BP-less,
Yeah.
there is no, you cannot, BP is unrecordable. If you have to go for a hysterectomy, it's not possible perhaps to have a second or a second opinion. But when you are doing a hysterectomy in a normal circumstance or in this kind of PPH, the second opinion is probably very essential. Especially, I think Gitendra will agree with me, especially if it goes to code. So a second opinion always helps
Right.
if you have that option.
So since we are on this question, we are not referring to this particular case, but Dr. Tabassum, any experience with this so-called brace suture? Have you done it yourself? Do you find it's as easy as the textbooks describe, or it's a little more complicated?
B-link suture, yes, for the beginners it is difficult, but once you have done several times, I think modified B-links can be easily applied. But easier suture would be one suture like go through in, out and tie it up above. So block sutures can be applied. They are much easier and they also prevent the hemorrhage as effectively as B-link sutures.
And Dr. Pratik, regarding
Yes, ma'am.
B-Link, in fact, we have met personally in the B-Link in some conference, and he himself recommended that you trained your doctors or subordinate or yourself in some normal cases. That like placenta previa you try, only then in the PPH you
Absolutely.
can do hurriedly.
Absolutely. Pranjal, madam, any
Yes.
final words regarding brace suture before we move further?
These are breast suture. Yes, we have to practice it, like Maheshwari madam said. Yes, we have to practice. Sometimes these like we have newer modalities like YouTube and etc, and there are lots and lots of video by Dr. B. Lynch itself. So we can go through that videos, we can mentally prepare or we can mentally practice that, so that during the time of battle patient doesn't bleed. If we sweat during leisure time, the patient won't bleed. So yes, very big yes for learning the billion suture. It is very life saving.
So the
And one
correct
final word.
identification of the case for the B-link suture is essential. That
Correct.
is the primary thing.
It's
And your
more for
assistant
atonic
also should,
PPH. It's more for atonic
It's
PPH
oatonic.
rather
yeah.
than traumatic PPH.
Yeah.
Dr.
And
Pooja, one last question before we move to the next case. Any experience with these alternative Cho sutures and the other things which are described in the textbooks? Have you used them yourself? You'll need to unmute yourself. Ma'am. Please unmute.
At Vadia, we generally take the U sutures.
Okay.
So
And
I
they
have
work quite well.
experience with the U sutures, yeah. They work quite well, yes.
Okay. So since we are running short of time, I want to do one last question before we close. This is a 35-year-old Gravida 3 para 2 living to previous 2 elective cesareans. Ultrasound is showing an anterior placenta previa. You want to plan an elective cesarean, and when do you want to do it? Dr. Biswajyoti, stage is all yours.
You have got a patient who has got 2 previous cesarean sections, and you don't want this patient to go into labor basically. So you plan an elective cesarean section. I would rather do it around about 38 to 39 weeks, not at 37 weeks. I would ideally do it around 38 weeks. Now, regarding when you are planning for a cesarean section in this kind of patients, if you have a reliable ultrasonologist who had mentioned that the placenta is at the upper segment, I think you don't need to worry. But if the placenta is at the lower segment, in this kind of cases, there we will have to be extra careful, and if the placenta is at the lower segment and you have done a transvaginal ultrasound, or you have done a MRI to find out that there is a placenta accreta, then your approach will be completely different.
Correct. So I think here what we are trying to highlight and point out is often we don't pick up the phone and talk to our radiology colleagues. We assume that they understand the risk factor that comes with a previous one or two cesarean section and a subsequent pregnancy. They may not always have that in the back of their mind. So please pick up the phone, talk to them, say that this is a high risk patient. I'm suspecting that there may be a morbidly adherent placenta. Please use every single whatever instrument you have at in your armamentarium to try and identify that this is a morbidly adherent placenta before she reaches term. If you identify it well in time and in advance, like Dr. Piswajyoti sir was saying, you will be saved. Otherwise, you will land up in a major soup. And again, this is something which we are seeing more and more often today because we have been very liberal with cesarean sections. And not everybody does a cesarean like you do. Not everybody is as meticulous with hemostasis and uterine incision closure as you are doing. There are various different practitioners with various different levels of expertise. I'm not saying that unskilled people are doing it, but it's always wise to keep in the back of your mind that the cesarean that you do is not like what other people do, and therefore even though on the front page you will see cesarean section done, whether it was elective or emergency, what actually happened inside, what is the healing afterwards, what is the strength of the scar, whether it will sustain the subsequent pregnancy, and whether the placenta is going to be adherent, to what extent it is adherent, whether it is completely through, that is something which we cannot predict unless we have that in the back of our mind and we communicate with our colleagues. Would you agree, sir, Dr. Indranil?
Yes, sir, definitely. And as Sir Bishwajit sir said, we can add one more point. Usually, when we have cases like this, I request my radiologist to look at the scar thickness as well as use the Doppler also to check for any abnormal vasculation in the and that area if the placenta is like in the lower segment.
There is a whole laundry list again, which the RCOG and the ACOG has given, and this is just reproduced here for your knowledge. All of us are aware of these things, but often we don't communicate it to the junior colleagues. Often we don't communicate it with the other colleagues who are responsible for the care of the patient. Ensuring proper communication and identification well in time is the key to preventing catastrophe in this patient. After you have identified it's a morbidly adherent placenta, you're going to take every single precaution. You'll get a urologist, you'll get a surgeon, you'll
Interventional
uterine artery,
radiologist.
you will do your uterine artery embolization, sub
Yeah, everybody.
But if you don't identify it in the first place, then the first time you will do it is when the patient is opened up in the middle of the night in an emergency when you have absolutely nobody to help you. So the key here is identification in time. The last question is for our esteemed medico-legal panel expert, Dr. Geetendra Sharma sir. Unfortunately, this patient has had massive PPH despite all our efforts. She has passed away. How do we break this bad news to the relatives, and what precautions do we need to take? This is a very real problem because in today's world, they will first hit the doctor. Nobody is bothered about court case. Nobody is bothered about police case. They are first going to come and hit you and smash your hospital to pieces because they are reacting in a different niche of fashion. Dr. Geetendra Sharma, sir, all yours.
To deal with this kind of cases, first we have to, our approach should be preventive. So we have to counsel stepwise at the time of complication, as mentioned by Dr. Pooja, that we should have one system, that one person should counsel simultaneously to the relatives of the patient that what is going on inside and what doctor is trying to do. There is a dictum in law that justice is not only to be done, but it should seem to the people that justice has been done. So in the same way, treatment is not only to be done by the doctor, but it should seem that doctor, whatever is possible, doctor is doing for the patient to save the patient. So if you are able to convey that thing to the patient's relative, then nothing will happen. But if you are not able to convey that you have done your level best, then only the problem occurs. Whenever such problem occurs, then it should be dealt with three ways. First, breaking the bad news, as you have said. So before breaking the bad news, it is a good thing that you should prepare your documents or you should complete your documents. Second thing, that you have to deal situation in three ways. One is social, second is medical, and third is legal. So medically, you should take care that in operation theater there should not be any drug which is expiry date, so that if somebody will come in future to check, then you will be in problem. Never ever prescribe any emergency medicine in such cases, so that it will prove later on that you did not have stock of emergency medicines. All whether all machineries are in working condition, you have annual maintenance contract of all the machines or not. So everything should be checked. Then second thing is that breaking the bad news is an art. There is a method known as spike. So according to spike method, S means you should sit down on your chair and with eye to eye contact, you should explain to the relatives of the patient. Now you have to select the relatives. You should not call at random 5 or 10 people inside, but you should select that who can who, from the mob, that who can understand you in a better way. And the person who is educated one should be called inside. Near relative should be called inside, and you have to explain to the patient the bad whatever has happened inside the operation theater. P means you have to perceive, means how much patients relatives are perceiving your explanation. So you are supposed to ask question to them after explanation, that what I have told, whether they have understood in a proper manner or not, that is to be confirmed. I means you have to allow interactions. So if they want to ask any question, give them clear cut answer calmly without losing your temper. K means knowledge. You have to give them knowledge that what has happened inside operation theater or labor room, what you have done, and why this situation has occurred. And last but not least is the E, that is empathy. You must have empathy. So while taking tea or coffee, you should not explain, but you should properly explain with empathy. And that you should explain that you also have sympathy with the relatives of the patient, and losing patient is something great to me, something loss to my personal loss. Last but not least, whenever there is a gathering of mob, for your safety, you should do a few things. That you have to inform police as early as possible, so that if you will inform police, the police will definitely come and protect you from the mob. Second thing, if you keep CCTV camera in your hospital, that is always a better thing, because in such circumstances, if mob does something wrong, then you have to recording of that. And last but not least, you have to inform insurance people, or you can call your colleagues for the help. So you should have a rush team in your area, and you can call a few of your friends to support you in that circumstance. So if you can create your mob in front of mob of the relatives of the patient, then you can definitely save yourself from this. Last but not least, my all the friends used to say that you should keep one door from the back side to flee away.
Thank you, sir. That was fantastic, and we really value your inputs. That was amazing. I think these are key take-home messages for everybody. That having done our best, if we don't document it, it is as if
It's
it
not
never
done.
happened.
Yeah.
Ensuring adequate teamwork, that's another very important message for today. And of course, at the end, as we said, Dr. Gitendra Sharma said, that we need to always be able to rationally and properly, with empathy, explain the entire sequence of events to the patient's relatives. Before we close this panel, I'd just like everybody to give one single take-home message for the audience. We'll start with Dr. Pranjal Sharma, madam.
For PPH, it is intelligent anticipation, skilled supervision, and prompt detection of the things, and effective institution of the things, and training of the staff.
Fantastic. Wonderful. Professor Datta?
Institutional delivery is the way.
Yes. I can totally see where you're coming from. Dr. Biswajyoti, sir?
Skills and drills. I think that is very important, and timekeeping, proper scribing, everything. So skills and drills is very important, and it should be done regularly with the full clinical staff involved in taking care of any obstetric patient.
Lovely. Dr. Pooja Bandekar, madam, please unmute yourself. Please unmute.
You had asked in the beginning how important is PPH now. So to quote in terms of art, Taj Mahal was also built as a tomb of Mumtaz and she had died of PPH. This was centuries ago. PPH is like COVID, it's not a disease of the low or the high socioeconomic strata. It is always there. So PPH था, है और हमेशा रहेगा. And I
Hopefully
think we
हमेशा
all
नहीं
need to
रहेगा.
remember that. हाँ?
Hopefully
Yes, sir.
हमेशा नहीं रहेगा.
होपफुली हम इतनी
COVID
मेहनत
is a
करेंगे कि
PPH.
नहीं रहेगा.
सर PPH, COVID तो पता नहीं, लेकिन PPH तो था, है और रहेगा.
डॉक्टर भारती महेश्वरी मैडम.
जैसे पूजा ने कहा कि पीपीएस था और रहेगा, तो मैं हमेशा यही कहूंगी कि हैव नॉट टू बी पैनिक, कॉल फॉर हेल्प एंड एंटिसिपेट एंड रेगुलरली ट्रेन योरसेल्फ.
Thank you. Dr. Tabassum Dalla, you are there at the end. I think you are in OT or you are just coming out of OT.
I am going to OT now.
You are going to OT, okay.
I would say that PPH तो जैसे मैम said रहेगा, but mortality नहीं रहना चाहिए. I think mortality should be prevented. As we discussed that misoprostol, yes, in periphery should be judicially used, and skills and drills is very important. All the staffs should be taught and regularly taught. It's not like once in a while we have one maternal mortality and then we have a meeting and we have a drill and then we forget for three years again. So I think every month we should have a day fixed and have skills and drills for all the staff and ourselves as well.
Dr. Geetendra Sharma, sir.
But as we know that it is an unpredictable thing, and to deal for any unpredictable thing, the only weapon in our hand is proper pre-counseling. So even in antenatal period, you should counsel the patient. You should do counseling to the patient and explain them that what kind of unpredictable things can happen, so that you can prepare them such complication if occurs. Counseling, communication, and documentation are the key to avoid medico-legal problems in PPH.
So much, sir. Thank you to all the esteemed panelists, Dr. Pranjal Sharma, Indranil Datta, Dr. Bharti Maheshwari, Dr. Pooja Bandekar, Dr. Biswajyoti Guha, Dr. Tabassum Dalla, and Dr. Geetendra Sharma. All of you have contributed so wonderfully. I didn't really need to speak, actually. You were all answering, every ball was being hit for a 6, if I can say. And if we can actually continue, we could have continued for at least another 1-2 hours and still we would have not felt bored because there were more and more engaging discussions which were happening. Thank you so much for joining us as the convener for today's program. It's my proud privilege to present the official vote of thanks. We'd like to express our gratitude to the among office bearers, our president, Dr. Nandita Palchetkar, our secretary, Dr. Arun Nayak, the ICOG chairperson, Dr. Mandakini Meg, secretary, Dr. Parag Beniwale, who was one of the chairpersons for granting us the ICOG project point, Dr. Amey Purandare, Dr. Ramani Devi, Dr. Abharani Sinha, the other chairpersons, our two fantastic speakers, Dr. Bhaskar Pal, who spoke on role of LMWH in current obstetric practice, and Dr. Kiran Kotakoti showed us some fabulous videos and cesarean section practical tips. We had a wonderful panel at the end, and thanks to all the panelists who joined us and stayed with us well beyond time. Of course, we also need to express our gratitude to our academic partners, Bharat Serums and Vaccines, without whose educational grant this would not be possible. And finally, to Science Integra team, Subbu, Seshan, Shrimon, Sana, all of you do wonderful work. Thank you for being our backbone. Thank you for being with us always. We hope to see you all very soon in another program. Thank you so much.
Thank you, Dr. Prateek,
Thank
for
you.
wonderful
Thank you,
moderation.
Prateek,
And nice to meet you all, Dr. Geeten, Dr. Pranjal, Dr. Vishwajyoti, Dr. Pooja, Dr. Indranil Tabassum, and I think we met earlier in my MTP committee CMEs.
Yes,
Thank
yes.
you to give me opportunity to meet again all. Thank you, Dr. Prateek.
Thank you.
Wonderful.
Thank you,
webinar.
Dr. Prateek. Thank you. Thank you all the panelists.
Yeah.
My co-panelists. Thank you, everybody.
See you soon again in some webinar. Bye-bye.
Thank you.